I declare open this public hearing of the Standing Committee on Health, Aged Care and Disabilities inquiry into Thriving Kids initiative. I'd like to acknowledge the traditional custodians of the land from which we meet today and pay my respects to their ancestors and elders past, present and emerging. I extend this respect to all Aboriginal and Torres Strait Islander peoples and their cultural and spiritual connections to Australia's lands and waters. In accordance with the Committee's resolution of the 21st of August 2025, this hearing will be broadcast on the Parliament's website and the proof and official transcripts of proceedings will be published on the inquiry website. I remind members of the media of the need to fairly and accurately report the proceedings of the Committee. I remind all public officials and stakeholders who are present before us in ensuring the safety of children during these proceedings. This includes avoiding the use of names or identifying details when referring to children and ensuring that any discussion involving children is respectful, appropriate and consistent with our shared responsibility to maintain a safe environment. We will not also be publishing unauthorised pictures of children in our inquiry papers. I invite members of the committee to introduce themselves.
Good morning. I'm the member for Kooyong in Eastern Melbourne and a former paediatric neurologist.
Yep. Mike Freelander, member for Macarthur out of South Western Sydney, chair of the committee.
Anne Stanley, member for Werriwa, South West Sydney.
Sophie Scomps, member for Mackellar on the Northern Beaches of Sydney.
And online we have Ali. Would you like to introduce yourself?
Hi, I'm Aileen France. I'm the member for Dixon in Queensland.
Good. I don't think we have any other members online as yet. No. Good. Now, I'd like to welcome representatives of the Royal Far West, Ms Jacqueline Emery, appearing in person, and representatives of Marathon Health Limited appearing online. For the Hansard record, would you please, before giving evidence, state your full names and the capacity in which you appear before the committee? Although the committee doesn't require you to give evidence under oath, I should advise you this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now would like to invite you to make a brief opening statement before we proceed to discussion, and then to assist with the transcription of the public hearing, it would be appreciated if you could state your name before responding to each question. Now, I'd now like to invite perhaps Ms Emery first to give a brief opening statement, and if you could keep it to under 5 minutes, that would be great. Thank you.
Thank you. Thank you. Jacqueline Emery, CEO of Royal Far West. I'd also like to acknowledge the traditional custodians, the Ngunnawal and Ngambri people, and pay my respects to elders past and present and children that will become our future elders. Thank you very much for the opportunity to speak today. Thriving Kids is our opportunity to close one of Australia's most persistent and preventable gaps, the developmental gap between urban and rural children. Right now, nearly 60% of remote children are just not ready to start school. That means more than half of these children will start behind before they even walk through the classroom door. Emotional vulnerability is rising sharply in regional areas. These are not just statistics, they represent futures at risk. The first years of life are critical. If we miss this window, the cost isn't just emotional, it's economic. Every dollar invested in early childhood saves up to $7 in future health, education and justice costs. This is one of the smartest investments we can make. Let me share Sophie's story. She's 5 from far western New South Wales. Her mum noticed that she was struggling with speech, but the nearest specialist was 400 kilometres away. Her speech issues were also starting to impact her confidence and behaviour. We were able to assess Sophie in person at her kindy, and together with her mum and teacher, we worked as a team to set some goals around her speech sounds. Through just 8 to 10 weekly telehealth sessions, we improved her ability to communicate and her confidence in the classroom. For Sophie, if she didn't get the help we were able to provide, she would have started school already behind. This is not an isolated story. It's the reality for thousands of children across rural Australia. These systems aren't just about distance. These gaps, aren't just about distance. They're about systems. Rural Australia faces a health workforce crisis. GP access and the availability of allied health, particularly in MMM5, is declining. Bulk billing rates are falling and locum contracts are unsustainable. Paediatric waitlists can stretch from 18 months to 6 years, and private assessments cost up to $3,000. We receive consistent reports of a 2-year waitlist for allied health. Teachers are managing complex needs without support. Families are under financial and emotional strain. Our rural communities are losing young families because services simply aren't there. Families in thin markets are just not getting the help they need at the time where it makes the most difference. This is structural, not situational. Thriving Kids gives us a blueprint to change this. The principles are clear. Prioritise early developmental screening and intervention so we don't miss critical windows. Invest in rural workforce pipelines, training, supervision and retention tailored to regional needs. Align health, education and child protection systems to stop siloed care. Support flexible, region-specific solutions because thin markets can't be served by market-based models. Embed cultural responsiveness and trauma-informed practices so care works for every child. Community-based engagement is key to successful implementation. We need to leverage local networks such as AMSs, GPs, paediatricians, allied health workers and early learning centres to ensure clear transition pathways that families can navigate from early years to schools. Without coordination support, or glue, families fall through the cracks. We also know that many rural communities don't even have these local networks. Royal Far West already delivers 42% of its services in schools and preschools in small rural towns, showing practical success where others struggle. Unlike metro-centric models, Royal Far West's hybrid approach combines telehealth and local face-to-face care, overcoming chronic workforce shortages and geographic isolation. This is not theoretical, it's operational and it's ready to scale. We urge the committee to invest in evidence-based, community-driven solutions, prioritise early developmental screening, coordination resources, workforce training and trauma-informed practices because every child, no matter where they live, deserves the chance to thrive. Thank you.
Thank you very much, Ms Emery. We might just get a representative from Marathon Health to give us a brief outline. Thank you.
Portfolio Manager for Allied Health Western and speech pathologist.
Sorry, could you just, we just missed your name. Could you give your full name again, please? Sorry.
Sure. Kylie Irvin, Portfolio Manager and speech pathologist at Marathon Health Western.
Yep.
Thank you for the opportunity to appear today. I'd also like to start by acknowledging the traditional owners of the land on which we're meeting, and I pay my respects to elders past and present. Marathon Health was established in Western New South Wales in 2015 to address gaps in high-quality community-based health and wellbeing services for people living in regional, rural and remote areas, and we now deliver face-to-face services across 75% of New South Wales and a virtual service Australia-wide. As a non-profit organisation, our vision is to empower these communities to thrive through equitable health and wellbeing. All of our 280 employees live and work in regional New South Wales, giving us a unique insight into the challenges and barriers families living across regional, rural and remote New South Wales face. Across all of our programs, 27% of our clients identify as First Nations. Marathon Health is a key provider of community-based early intervention supports to children across rural, regional and remote New South Wales, and we welcome the opportunity today to provide information that will support equitable access for families no matter where they choose to live. Today I will speak from my perspective as a speech pathologist with more than 18 years experience delivering services to children living in rural and regional New South Wales communities such as Dubbo, Cobar, Nyngan, Lightning Ridge and Walgett. My colleague, Kylie Falciani, is a senior social worker and operational manager who has extensive experience in integrated care coordination across the lifespan in regional and rural New South Wales. From this experience, I can testify the difference that early intervention services and supports can make in a family and child's life if they can access them, and unfortunately, the impact on children and families when they are unable to access these services. Over the past 2 years, I've had the privilege to lead the co-design and delivery of the Flying Start Paediatric Service in collaboration with remote communities in Western New South Wales. This service brings together local supports to provide families in rural New South Wales with free access to a paediatrician in their local community, unlocking access to ongoing health, education, carer and social supports based on each child's needs. To date, over 70 children have accessed this free holistic assessment by our paediatrician. More than 80% of these children identify as Aboriginal or Torres Strait Islander. Unfortunately, despite us being ready to scale, at this stage, sustainable funding for this service has not been secured, leaving many children on wait lists and no guarantees for service. We've recently expanded this program to the community of Mudgee, where we had a waiting list of 12 months to see the visiting paediatrician before he had even conducted his first clinic. With the current climate of change, I believe that we have a unique opportunity to create a system focused on collaboration, universal access, early intervention and evidence-based practice, particularly for our most vulnerable in rural, regional and remote communities that are often overlooked. We have an opportunity now to invest in creating a community-based workforce alongside service delivery.
Thanks. So I might just stop you there because in the interest of time, we'll open it up to questions, if that's okay.
Absolutely.
Thanks. Monique, would you like to start?
Yeah, thank you. Thank you, Chair. Thanks for appearing in front of the committee this morning. Ms Emery, I'm interested in, you mentioned the importance of early screening and intervention for developmental problems, which is something an issue on which I think you're probably in furious agreement with all of us. How do you propose that we optimise that in the rural and regional settings where there are thin markets for providers?
I think the first thing is that we need a sustainable approach, and so long-term sustainable funding is really critical to that. We ran, as you know, we reported in our submission, the Healthy Kids Bus Stop service for 8 years. And if that didn't kind of showcase the need, I don't know what would, because 80% of the children that we screened needed a referral to another service, primarily speech and audiology. So there's huge need. One of the issues with the Healthy Kids Bus Stop was there were not readily available referral pathways into local services because there just weren't the local services. So it's important to screen and identify issues, but you also need a level of support. Now, again, by way of Sophie, the example of Sophie, if you get in early enough, you can really make a big difference in these issues before a child actually starts school or through that transition process into school. So I think that getting back to your question, we need to leverage what's available within those thin markets, because not every community is the same. So that's really important. But you do need a consistent approach to this. So, there are providers like Royal Far West, like Marathon Health, that have the capacity and capability to run a service like this in thin markets. Some of the issues for providers like us and other providers is that sustainable funding in order to do the job in a consistent way that provides consistent staffing, so that that staffing, that workforce can build trusted relationships in those communities. And that's really key in these country communities, that level of trust, because they've had years of revolving doors of clinicians. So what we really want to see for a sustainable approach is an uplift in an understanding about the importance of child development, and that can come through that sustainable approach to screening every child, but actually doing a proper allied health screening of children's needs, and then absolutely connecting them back into the public system where possible for those referral pathways.
And how do we get that screening done? Who does it initially? Who's picking up these issues in the first instance?
Well, that's a great question, because obviously we do a lot of our work and we're in 387 rural and remote communities. Most of the referrers are educators, either in early learning settings or schools. They're often the first people that pick up that children may be struggling. Parents are often living in isolated areas. They're not kind of at your local local play group actually comparing their children with others in terms of their milestones, so often they miss out on that. And so, and there's a prevailing view for a lot of parents, it's okay, they'll get sorted when they get to school, and we know that then that pushes out that window for support and help. So I think that what concerns me is that ECEC is really important part of this, because increasingly that's where we find children, but we also need to make sure the system reaches those children, and these reforms reach those children that are still not presenting in any of those settings. They're still not necessarily turning up to the GP. And again, when you build those trusted relationships with community and you work with local community groups, you can find those children.
That's a really good point, and that's one of the things we've been discussing as a committee in recent weeks, the issue that many of the kids that are probably most at risk are not going to early childhood care and therefore potentially falling through the cracks. So your suggestion is that it's through community engagement and... Okay.
And if I could just add to that, it's Kylie Irvin here. I agree with what Jackie has said. And I think in some small and very remote communities, educators in some of the centres don't necessarily have the time or the confidence in making some of those decisions around identifying children who are at risk. So I think it's really important to have allied health clinicians, speech pathologists and OTs in particular, who can come into those centres often, who can be there to build capacity of the educators in the settings, and then also link children through to pathways where that is required as well, particularly through enabling roles such as allied health assistants and paediatric linkers, and having those local people on the ground in communities who are familiar with all of the different services in each individual community is a huge value add as well.
Agreed. Thank you, Chair.
Good. Sophie.
Thank you. Sophie Scomps here, MP. Obviously, there's a huge lack of local services in rural and remote areas. How effective do you feel the telehealth services are, and what type of model should we be looking at to provide better care, more comprehensive care, early intervention?
Thank you, Jacqueline Emery. A wonderful question. And, look, all of us would like to see local services in every town. And that's certainly our wish and our goal at Royal Far West. We probably have never had local services in every rural town. It's not an ambition to move away from. But the reality is that telehealth is a very effective model of care. We've been running our National Paediatric Telecare Service that's part funded by the Department of Health and Aged Care with over 200 schools since 2019, and in fact we piloted it even earlier than that in 2014 in Gladstone in Queensland. And we operate in all sorts of different jurisdictions. We've had that program recently evaluated, and we've seen incredible results that not just with children receiving telehealth who are achieving all of their goals that are set, a high percentage of all of their goals, over 90% of all of their therapy goals have been met, but also the ripple effect that we've seen by delivering these services into schools and preschools around the issue that Kylie raised around building capacity of those early educators and their confidence. They're very isolated in managing increasingly concerning behaviours, mental health issues, complex families, and they need that support of allied health professionals, even just how to navigate conversations with families is a really important part. And so working as a team, and we kind of see that as well in the integrated hub models, it's working, but we can't place the full burden of this on educators. So they're really important models. What we find with the telehealth as well is that it doesn't take children out of school. And we've got lots of scenarios. We've worked with Narromine Public School for many, many years. There was a student there that would have to leave before our work, would have to leave school, travel into Dubbo, which wasn't really that far away, 40 minutes on a bus ride. That child ended up having 36 sick days off school, or not sick days, but days off school to attend that session. Her mum had to actually take all of those days off work to attend that session, and then the travel costs. So there's, for families under financial strain and pressure, actually having these services delivered into these environments that have a lot of protective factors, there's a lot of huge benefit from that. I think the other real benefit of telehealth, particularly for young children, it's the weekly service and support and intervention that can make a big difference in a short period of time. Often when you're trying to access your local clinician, at best you might be getting a once a fortnight, once a month appointment. So I think it's got to be part of the mix. But again, I think that having the hybrid approach where you can actually assess kids face-to-face, you can build trust in those communities, and couple that with telehealth is really the best model.
Thanks.
Can I just clarify? Sorry, go Kylie.
You're on mute, Kylie,
Yes, Ms Irvin, go on, go ahead.
Thank you. I would just like to say I think that in many regional and rural communities there are already some excellent allied health services who just need continued investment to be able to deliver more of the services that they're already doing a really great job at doing. We typically travel 400 to 500 kilometres to provide face-to-face services to communities within our patch, children in our patch, and we will travel into those communities roughly once a month, sometimes once a fortnight, around about 300 kilometres home, and then like there and then back again that day or the next day. And I think we would view telehealth as something that complements this face-to-face service delivery. And as I mentioned, through adding in those enabling roles like paediatric linkers and allied health assistants, that can really complement that service as well, where families who aren't able to access telehealth, who might live on a remote station an hour from Burke, which is about 500 kilometres from Dubbo, they could have a person in the home working with them and then be supported through telehealth as well.
Thanks. Good.
And may I also add that allows our clinical team to be able to work top of scope, having that enabling workforce. And for us, it's an investment in programs and how we do it, but it's also an investment in building local workforce for sustainability, which builds trust within the community. So for us, it's about opportunities to support us locally to build our workforce alongside the programs that will be delivered.
Good.
Can I just clarify, so you're saying that the telehealth is best when it's delivered at schools or at the early childhood centres because you don't have to take the kids out of school, basically? Is that?
Absolutely. Although it doesn't need to be limited. It doesn't need to be limited to the school environment. I think the reality is often schools in rural towns are the hub of the community, but certainly community centres, Aboriginal medical services, it definitely has portability, and I think that all of those options need to be on the table, particularly in the under fives where there aren't ECECs, and we know the issues around childcare deserts.
And just one other thing very quickly, you mentioned an integrated hub model. Could you just explain that a little bit for us?
So obviously there, you probably would have seen through the submissions that integrated child hubs are really on the increase. I think there's around about 400 in the hub network now. I think that's a really good model. In effect, although we're not inside that hub network, we operate like hubs in that way, where we have those wraparound allied health supports on the ground, as well as via telehealth. And I think the really important thing as well, and it kind of goes to the last comments as well, how important a multidisciplinary team approach is, particularly, and I know the committee's thinking about the rising number of children that are developmentally vulnerable on 2 or more domains, now over 12.5%. And that's obviously a lot of the cohort that we work with. And, we work in a multidisciplinary team fashion with the schools and preschools that we work with because, children often have a range of different things going on, and so they need the support of speech, OT, psychology, and families often require the support of social work as well. And so I think that's really important when you're looking at that cohort. We can't have a one-size-fits-all for thriving kids because we know some children need more.
Thanks. Can I actually I'll ask Ali. Ali, have you got any questions?
Thanks, Mike. Thanks, Chair. I only just wanted to say that it's really, I think, from my perspective, I hear a lot from regional and rural families, parents in the disability community who are constantly just can't find the services or can't get the services that they need. So I'm just so pleased to see, services out there that are delivering these types of models of care, in terms of looking to what we need to deliver into the future. It's just so nice so thank you, both, all of you, for coming and giving us the time to hear what you guys do, because I think it's really important. That's all I wanted to say, Mike.
Thanks, Ali. I just want to explore it at a bit more of a granular level, because we are trying to look at solutions, and I think the work you do is incredibly difficult and complex. But I just want to ask Ms. Irvin how you get your funding and how you in particular recruit paediatricians to work for you.
Good question.
Can you explain to us how that works?
Yeah, absolutely. So our Flying Start paediatric model has been charity funded. So we worked with Variety, the children's charity, and that is who has supported us to deliver the first year's worth of paediatric allied health clinics. Mm-hmm. We found an amazing paediatrician out of the Bathurst area who was keen to do this type of work, had been in the industry for a long, long time and was looking for an opportunity to do something that would warm his heart. And so he's a really great fit for us, and we're subcontracting him.
Can I ask who that is?
Yeah, it's Dr. Timothy McCrossan.
Oh, yeah, good.
Yes, okay. I know it's a small world. You probably know Tim.
Indeed. Yeah. And
so we have been lucky. We have been working with the LHD just to try to get some more sustainable funding to allow us to deliver more clinics into 2026, because we're getting such excellent outcomes. We've had 95% attendance rate running our clinics in community, because all of the barriers of families accessing this type of services are removed. There's no cost. There's no need to travel. It's very supported by the local community.
Yeah. And is the Variety funding ongoing? Are they guaranteed on?
No.
Okay.
And so that's a big challenge, because we are ready to deliver this. We love delivering this. Yes. We just need someone to fund it.
Yeah.
Carly Falciani here from Marathon Health as well. A large part of effort, labour, is spent piecing together piecemeal of, I'm going to use the word scraps of funding to deliver this incredible, impactful service. Yeah. We know that MBS doesn't even is really hard, problematic, and doesn't kind of cut it to support, but it is a mechanism that we can use alongside. We've gone to RDN. We're pretty much trying absolutely every option to keep this within community, as well as managing that trust and relationship with local communities, because we do know the high percentage of First Nations community that we are supporting.
Yep. And can families refer directly to your service, or do you...
Yes.
Right, okay.
Yes, they can. Yeah, and then we partner with the local GPs in community to get this referral letter and then arrange shared care after the paediatrician consult as well.
And do you work sometimes with the Royal Flying Doctor as well?
Yes, we do communicate with them, and we do share resources and have discussions with their team as well. Yeah, they've been a good support to us.
And can you provide like a flying squad that can go into a community and do a multidisciplinary?
Yes. Yes, we do. So with our model, allied health assessment all happens before the paediatrician consult on the day. So our speech pathologist, our OT, the school psychologist, the WIN nurse, the GP, education team is all doing their work, preparing, I guess, all of the information and assessment that the paediatrician will need to make a diagnosis on the day. Then we form a care plan, we activate all of the referrals on the clinic day, and then we're able to link with education-based supports, NDIS supports where that might be required, medication if that's needed, and it's just a really efficient model for families in community.
Yeah. Yep.
Saves at least 3 paediatrician visits is what the evidence is telling us through this model.
And you keep data as well as the number
Yes. Yes, we do.
Can we have access to some of that, the number of patients you're seeing?
We can send some things through. Yes, we'd love to share that.
That would be fantastic. What is the waiting time for your service? Because that is a big roadblock to many complex families.
Yes, well, we have a wait list purely because we don't have funding. Back and deliver another clinic. So in the communities of Walgett and Lightning Ridge, we've got about 15 children in each community sitting and waiting, and same in Canamble. And I've just been letting our referrers know as soon as we have funding, we will be ready to come back out and work in the community again.
So you're depending...
We have the model and the workforce ready to go. We just don't have the investment.
Okay. And do you triage your referrals?
We consult with the paediatrician where we need to, and we also consider important timeframes. So if it's a child who is about to turn 5 and will be starting school, we will prioritise seeing them so that they've got the education-based supports that they might need ready to start school. Likewise, if they're a child who is about to age out of the early intervention NDIS access, we'll prioritise those children as well so that they don't lose their access to that scheme and those supports.
Yeah, and you provide supports to the families?
Absolutely, we do. So we work with a paediatric health linker who's able to then help the family to follow up referrals, get their ENT assessment, go and fill their script, do the NDIS application if that's appropriate. It's a very well-supported wraparound service for families.
Right.
Yeah.
Ms. Falciani, could you comment on the complexity of the patients that are being referred to you? Do you make some comments around that? Sorry, you're muted. Sorry, you're muted.
I can talk to that. It's Kylie Irvin. I can talk to that if you like. The children that we've been seeing in the clinic model often have 3, 4 or 5 diagnoses made on the day. So they are really quite complex children, often non-verbal, toileting, communication issues, obviously sensory needs, meltdowns, really quite complex children. And then, of course, as you can imagine in those communities, difficult social histories as well. Developmental trauma is often present. So we are seeing really quite complex children and families who, some of these children aren't referred to our service until they turn up at kindergarten.
Yeah.
And the kindergarten teacher identifies because they haven't been connected in any other services up until that point. So they're, really desperate for support from our clinic model to support them with supporting the child at school.
Yeah. Now, do you get any state government funding?
No, we have not to date.
Okay. And how long is
For this program specifically, yeah.
how long's the Marathon Health been running?
Marathon Health, its 10-year anniversary was this year.
Okay, well done.
Yeah. Thank
Congratulations. Good. Ms Emery, you'd like to make
I'd just like to add some comments around complexity, because we've just recently completed some research with the Growing Minds Australia Clinical Trials Network. I'm a chief investigator on the Rural Telehealth Subcommittee in that, and we looked into complexity for families and engagement in multidisciplinary paediatric services. Looking at our getting a bit of feedback. Looking at our paediatric development program, our multidisciplinary program we've been running for 25 years. And I just want to give you some of these stats, because there are spheres of complexity, not just clinical complexity with these families. So 60% of parents or caregivers reported mental health issues. 59% reported seeing a parent caregiver being abused verbally or physically. 38% changes in relationship status of caregivers. 28% feeling unsupported, unloved, unprotected. This is children. 27% of parents or caregivers who insulted, humiliated or put them down. 20% of parents or caregivers with substance misuse. So there's some significantly complex children with adverse childhood experiences that really need to be taken into account around what's required in these communities where we've got a high proportion of disadvantage and vulnerability.
Now, a couple of questions. Is the service scalable that you provide?
Yeah, absolutely. So part of our investment from the Department of Health and Aged Care, we've grown significantly from about 50 schools back in 2019 to over 220 schools and preschools across 4 states. Part of that investment from the Commonwealth back in 2019 was actually a systems transformation. So we did a whole overhaul of our electronic medical record, our basically every system that we've got in order to make this a scalable service. So really we can go anywhere. Currently it's a co-contribution model, so schools fund the service really with the backbone of this service funded by the Commonwealth. We just had an additional year of funding because it came to the end of a 7-year funding period last year, as you probably remember. And again, we had to submit an evaluation, an independent evaluation of that program to the department this time last year.
Yeah. Can families self-refer?
Yes, they can. I mean, mostly families work with the schools, and often it is the school that might actually commence that referral process. So schools can put in any child that they want into that service. Does that
include the early childhood centres as well?
Yes, absolutely. And then, of course, with our other paediatric developmental program, which is only New South Wales based, that is part funded by New South Wales Health, and that does require a GP or paediatric referral, and that's a multidisciplinary assessment service that does service every rural and remote region in the state.
Yeah. Could that be scaled to national?
Yeah, absolutely. I mean, it's a comprehensive model for children. It's a Tier 4 service, and it's a comprehensive model of care. We also don't just assess children. It is a full multidisciplinary team with dietetics, psychiatrists, paediatricians. And then, of course, a lot of those families we continue to look after either through medication reviews where we can't refer them back to a local paediatrician, which is increasingly the case, or...
Why is that increasingly the case that you can't refer back?
Because there's just not the paediatricians and in New South Wales. And, you know, for the whole of Western New South Wales. We have 2 paediatricians trying to service that whole region, and not just, and they're not developmental paediatricians. So there's a real dearth of paediatricians. Murrumbidgee has a good paediatric, well, you know, reasonably, comparably good access, and in fact we're trying to support them to build their own local developmental paediatric clinic because they've got a few more paediatricians. But that's when I said wait lists can be up to 6 years for paediatricians now in parts of New South Wales.
Yeah, and the model uses partly telehealth and partly direct visits.
So this has been a long-standing program, which has really been our residential program in Manly. In the last couple of years, we've been working with health to start to deliver those services closer to home. So we've been running a Dubbo clinic because of the huge needs in that area, and also looking at ways of supporting in the Murrumbidgee region because they're our 2 largest referring areas. But families have been coming for that assessment program for 25 years.
So you do have the ability to provide sort of outreach clinic type?
Yeah, absolutely, absolutely. And we've just been funded to establish an allied health assistant model, which will be a local-based workforce, because we see so many mums and even teachers' aides in the schools that we work with that want to be engaged in the care and have a pathway to care. And we're also committed to building local workforce resource.
Great. Thank you very much. Yeah, of course, Ms Stanley.
Do you have any data that shows post your intervention how much better the kids are doing because you were there? Like outcomes-based data that either of you could share with the committee?
We've got a lot of outcomes-based data, and a lot of that was collected through the independent evaluation, but obviously through our funding models we have to report on outcomes all of the time. We've done lots of case studies around longitudinal, but we haven't done a longitudinal study. We haven't had the funds to be able to do that, but because we've been working, most of the schools and preschools that we've been working with now, we've had multi-year partnerships. We've been working with them. For example, we have a partnership with the Wilcannia Forbes Diocese. We've been working with them for over 5 years. We've been working, actually the PHN in Central Queensland has funded our early intervention model up there, and we've been working with the PHN there for over 5 years, working in up to 30 kindies in Central Queensland, delivering this wraparound support as well. So we've got a huge amount of data we could share on that.
If you could.
Carly Irvin here. We could also share data on our models as well. We were previously funded by the PHN probably 7 or 8 years ago to run a model which had allied health assistants based in local communities with clinicians coming in and out to deliver that early intervention type supports for speech pathology and OT. So that's a model that we're very familiar with. And then your other question as well around outcomes for children after they've had their assessment process, we definitely have some of that information. And an example that comes to mind is a young boy who was actually in Year 6 when we saw him in the community of Walgett. That was the first time that he'd had ever seen a paediatrician and a speech pathologist and an OT. And we were able to then get him NDIS access. So he has transitioned to Year 7 this year with some individualised supports for communication therapy, social and pragmatic supports, and to help him have a better experience in high school, and that's something that he wouldn't have been able to do without access to our program. His family wouldn't have had been able to leave community to access those kind of supports if we hadn't been right there.
Good.
Thank you.
Yep. So, Ms Irvin and Ms Emery, if you could provide us with some data around that, that would be great, particularly the numbers of children involved, and any outcome data would be great. So if you could provide that to the committee. Any other questions? No. Look, I'm sure there's a lot that we could ask you, and if there's anything you think we should know that we haven't asked about, please forward it to the committee. Thank you very much for your attendance here today and also for the work that you do. If you've been asked to provide any additional information, which you have, would you please forward it to the Secretary by the 14th of November 2025? I know that's not a huge time frame, but we are limited in terms of when we have to provide our report. You'll be sent a copy of the transcript of your evidence and we'll have an opportunity to request any corrections to transcription errors. And once again, thank you so much for coming along today and sharing your time with us. Thank you.
Thank you very much.
Thank you.
Good. And I now call witnesses from the Australian Association of Social Workers and Healthwise to give evidence today.
That was interesting.
Yeah, really good.
But I reckon we need to prove how much economically we will save in the future by making. Do you know? Because being council, I care about the money. Well, if you're going to fill in, do you know that?
Yeah, no, I know exactly. I agree. Good morning. For the Hansard record, could you please state your full names and the capacity in which you appear before the committee before giving evidence? Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I will now invite you to make a brief opening statement before we proceed to discussion, and to assist with the transcription of the public hearing, it would be appreciated if you could please state your name before responding to any questions. Now, I invite you to make a brief opening statement. If it could be less than 5 minutes, it would be great. I'll call first the Australian Association of Social Workers. Ms. Jennifer Lewis. Yeah.
Thank you, Chair. And thank you to the committee for the opportunity to attend here today. My name is Jennifer Lewis and I'm appearing on behalf of the Australian Association of Social Work, representing more than 17,000 social workers nationwide. We firstly commend the leadership of this committee and the department for the consultative approach being undertaken. I want to also begin by acknowledging the children and families who are at the centre of this initiative. We know their everyday realities give this work and these conversations such significance and urgency. The Thriving Kids initiative presents a significant opportunity. However, as this committee has heard in previous hearings, there are several challenges that must be addressed if it's going to fulfil its full potential. Success will likely depend on many things, including genuine co-design, clear communication, coordinated governance between systems, sustainable funding and workforce strategies, and a transparent, staged rollout with ongoing monitoring and evaluation. Ultimately, it will require a multidimensional and genuinely collaborative approach, one with allied health at its centre. There is no question the fundamental role medical practitioners play. However, allied health professions often carry this support and engagement into the home or other relevant contexts, and we do so in partnership with the child, family and other key people or structures in their networks. The social work profession is therefore well placed to complement the broader workforce in achieving the goals of this initiative. Social workers are already embedded across various sectors, with around 2,500 currently in the disability sector. While I unfortunately do not have broader stats regarding social work available, we do know that 30% of accredited mental health social workers were based outside metropolitan areas, 31% have availability within 1 week, and nearly 10% have availability within 48 hours, showing the profession's ability to enhance responsiveness and access, including in rural and regional communities. Social workers are skilled in holistic assessment and therapeutic intervention, with the accredited Mental Health Social Worker Survey revealing that this cohort draws on more than 35 assessment tools, scales and methods, and more than 40 therapeutic modalities in practice. This helps enable individualised, evidence-informed approaches that strengthen interventions across disciplines and help ensure integrated, family-centred care. Australia has one of the world's strongest disability support sectors, and if designed and delivered with care and respect that this initiative demands, and with the voices of those with lived experience authentically embedded in its design, delivery and evaluation, this initiative can become a leading, trusted and inclusive framework. Without genuine inclusion, we risk undermining the very outcomes this initiative seeks to achieve. Social workers are positioned, ready to contribute, not as a separate voice, but as a part of a united effort to ensure that every child can truly thrive.
Thank you. And now from Healthwise, would you like to make an opening statement?
Thank you. Good morning, Chair and Committee. I'm Louise Ingle, the Manager of Research and Partnerships for Healthwise. Thank you for the opportunity to further contribute to this inquiry. I'll acknowledge the traditional custodians of the lands and waterways of Canberra, the Ngunnawal people, and extend that acknowledgement and respect to the traditional custodians of the lands and waterways where we live and work in northern New South Wales and southern Queensland. I'm based in Tamworth, one of the rural and regional locations from which Healthwise provides services. We deliver primary healthcare services to regional, rural and remote areas of the New England and northwest of New South Wales and the Darling Downs and West Moreton regions of southern Queensland. Our core business includes delivering mental health, allied health and Aboriginal health services to those in the community who would otherwise not access services. We also deliver care navigation to Yazidi humanitarian entrants to Australia. We champion sustainable investment in healthcare, in health literacy and early access to services for the prevention or the delay of disease. We are celebrating 10 years of service in 2025 and we're pleased to be recognised for our work outside core services as one of 3 finalists in the Health Innovator of the Year for Rural and Remote Australian Health. Developing solutions to health access and rural workforce issues is one of our organisational strengths. Our organisation has a long history of relevant service provision, speech pathology and occupational therapy services to children in towns like Narrabri, Weewar and Moree. We deliver NDIS services, are engaged as contractors in schools, as well as delivering priority allied health services to community members across the lifespan in smaller population centres. Our wider workforce includes Aboriginal health workers, Aboriginal health practitioners, dietitians, mental health nurses and other mental health professionals, primary care nurses and lived experience peer workers. I'll now hand over to my colleague Sally.
Thank you, Sally Urquhart from Healthwise. I've got experience working as a speech pathologist in hospital, community health, private and charity sectors in Australia and overseas, and I've seen lots of different funding models for children who are in scope for this inquiry, so those children with developmental delay and mild to moderate autism. And I've seen rural, I've heard rural, the word tossed around a lot this morning and used well, but I encourage the committee to ensure that rural voices are the ones that you're hearing, not people necessarily providing services from elsewhere to rural areas, and that's where we sit. We're a local provider. I also think I urge you to look for strengths in the sector that we have at the moment and expand those rather than develop a new solution for us to come to grips with. I think local solutions and workforce development are the key things. And I think we've got examples of how we've done that in our patch of New South Wales, which I can talk about, and also we've got ideas for what we do have that could be expanded not necessarily that Healthwise is providing, but some state and federal initiatives that are there that could, I think, be part of your solution.
Great, thank you. Well, we might open up to questions. Sophie, would you like to start?
You start. I'll just have a
Okay. I've got a few questions. Who funds Healthwise?
So it's a charity. Most of our funding comes through the primary health networks. So that's federal
PHN funding, mostly.
health funding. Sorry.
PHN funding?
PHN funding. There are major funders, but it's all competitive commissioning, and we have other funders too, but PHNs.
Yep. And how long are you funded for with that funding?
So this is our big issue in the world. Most of our funding contracts are 12 months.
Okay. So that makes it difficult to develop a workforce.
It sure does. Yeah, we've got staff on permanent contracts, but we live with 12-month service delivery contracts, and that is our biggest issue.
Right. And with the PHN funding, I presume a lot of that is federal funding?
It is, yes. It is federal funding coming through the PHNs. The PHNs have a program called Priority Allied Health Services, which I think is very much important for this committee to hear about. So we have a contract with a local PHN to deliver that, and that's how we fund our speech pathology, occupational therapy, dietetics, and other allied health services in the towns that we work in. And it is a potential solution, expanding that, because it's only targeted at areas that don't have, a good ability to recruit and retain allied health services. Therefore, the smaller towns, the towns like Narrabri, not like Tamworth, if that makes any sense to you.
Yeah. And you have mostly block funding, I'm assuming?
It's always it's a contract to deliver a certain number of sessions, and within that we work with the PHN to meet the needs as best we can with the workforce we have.
Right. And is your service scalable? I've asked this to other providers. Can you increase your scope of practice or the number of towns you see easily?
So probably the two barriers to doing that are recruitment and funding. So we could to a small degree. We couldn't to a large degree. And I talking about national scalable models, telehealth, that sort of thing, outreach. Yes, I think there is a place for that. But those things sometimes work against us as local providers. And I think, so what we want to do is build on the strengths of what we have. I do have an example for you. So we, the speech pathologist working at the Narrabri Public School and the school staff realised that instead of having, 5 children in each new kindergarten class that didn't know how to rhyme and they didn't have phonological awareness skills, it was a small number, a small proportion of children for many years, but 10 years ago it became obvious that it wasn't 5 or 10, it was half the class or it was 3/4 of the class. And so they developed a model, it's called Sounds Good to Me, and it was something that early childhood educators in that town put into practice in early child education settings.
So they could identify the kids. And
they could teach the whole class how to rhyme, how to understand how to hold a book, where a sentence starts, what a word is, those pre-literacy skills. And I think, there's children in those classes that have been read to at home and there's lots that haven't, and so it effectively levelled the playing field for children. They could start kindergarten having the baseline skills to learn. They weren't starting from behind. And so, something like that is scalable, but it also has benefits beyond that cohort of children or those teachers, because we want confident early educators and educators in general, and training is something that helps with that.
So you do that with the early childhood sector, you're able to go in and train
So that we deliver that for a small cost. That is not funded. That was a local solution that, on a shoestring.
Great. Are there similar models in other PHNs around the bush or not?
So priority allied health services is, yes, other PHNs would have that funding in rural areas.
And there's other examples so multidisciplinary teams have been held up as a solution to delivering where there is a lack of rural workforce. That could involve external people to a town or local. We're actually delivering a multidisciplinary team pilot at the moment, not specifically for children, but for another chronic condition targeted to an LGA. And one thing which hasn't been raised this morning yet, but I know has come before your inquiry already, is the level of digital interoperability. And there are many solutions we could roll out, but at the moment the solutions are being guarded by the capacity of digital interoperability and safe information sharing. So I know there's things outside this inquiry that could influence that. There's the elevation of the allied health workforce plan, there's the digital health strategy as a nation. But I think if we considered having a local workforce who could work together as a multidisciplinary team in that type of example or otherwise, children would benefit, but we need things to come together.
Sure.
Yeah.
Do you think it's happened like an early childhood centre will contact you to go in there?
To go in, help train their trainers. So before appearing today, we spoke with all our allied health staff and asked for their specific input. They're working with rural children every day, and they have been approached by early childhood centres to come in and help train their staff and become aware. We are also engaged, if those centres have some funding, which some do, to come and deliver work inside the centres, which is great, but it usually requires a member of the staff as well as our allied health professional to be there. And we do believe this is part of the solution of thriving kids to be able to deliver in different settings. Whether that's early childhood schools or also having an option to operate in clinics, as some families have indicated they would like a choice.
And so the families can contact you directly if they have concerns about their kids?
They can. There is the option to do that. We also, through PARS, can receive referrals from schools, Aboriginal health workers, other people in the community who are aware that the service exists.
Right. And do you work well with the Aboriginal controlled health centres?
We do work alongside them, yes.
Yeah. Okay. And do you have access to paediatricians?
Not much. Not
Right.
much access.
And is it a problem? I should really ask.
That is a problem. We do facilitate a paediatric clinic in Narrabri, and that's through funding through the New South Wales Rural Doctors Network. It is remarkably, we have a 100% attendance rate at that clinic. Yes, and it's going well. And actually, it too was a partnership between the school, Narrabri Public School, Healthwise, and we brought RDN in, and so it's a great local model, and it's something that I think could be a great structure and enabler to thriving kids.
And who pays for that?
It uses state resources in the fact that the school WIN nurse is a vital part of the team, so that is partly a state contribution. In the course of their everyday work, they're identifying children. Right. It's specific to this LGA again, so it's not overwhelmed as it would be as soon as someone knows there's a paediatrician available. So that is a joint effort in the fact that nurse is vitally important to identifying and supporting children outside of the paediatric appointment time or their services as well.
Right. So she can actually seek out the kids that need that
That's
service.
right. And that is sort of part of the assertive outreach, which you indicated before. We do know there's children who, while this Thriving Kids has been looked at as taking people out of NDIS, we know there's children with developmental delays who don't we don't know where they are, but we can use assertive outreach as local providers. Okay. We have other entries to communities that could be in other group work that we do or other parts of their family life that we operate in, and we would be able to draw them into a service rather than waiting for them to present in an education setting.
Great, thanks. I don't want to take up all the time. I notice Sam Birrell's just appeared online. Do you have any questions, Sam?
Yeah, thank you, Chair. And sorry, there's a clash with today's meeting, but I've just stepped out of something because I did want to talk to HealthWise. I have looked at what they've been doing, and it seems to me a very interesting approach to regional and rural coordination of services. And so apologies if I've missed this, but I just wanted to ask the representatives from HealthWise about the importance of resourcing any design program in relation to regional and rural, so that any coordinating body has the professionals to access, and whether that's a problem where you are.
It sure is a problem where we are, that's right. And I think people have already spoken today about this being an opportunity to invest in not only individual and social outcomes for children involved with thriving kids, but as a nation as well, economic outcomes. Early intervention is an investment. We have one potential, I guess, part of the solution that we have mentioned briefly was expanding the Priority Allied Health Service program that comes through PHNs, and that would allow providers, not just us, but other providers like us that employ allied health services in rural areas to expand what we do. I think there's opportunities to enhance and expand state-funded initiatives. The Wellbeing InReach nurse is something that it's relatively new, and it is proving successful. So that is nurses in some schools in New South Wales, not all, but it has been recently expanded and could, I think, in my opinion, be expanded further. So they're employed by hospitals, by local health districts, and they are nurses. They have access to health referral and information systems, but they work in schools sort of 1 day a week. So in any given school, they might be there once a week or once a fortnight. They are a trusted voice for families because they're nurses and they're in school, so there's relationships and there's expertise. And we've seen them work well in our area. If they could be, which they don't currently do, but if they could potentially sort of connect with families or younger siblings that aren't at school yet, then that brings that first touch earlier. I don't believe that early childhood educators have trouble identifying or screening children. I believe the problem is then what to do with those children, and that's where allied health professionals come in.
Yeah, I think you're right. Thanks, Sam. Anything else?
Yeah, just a quick follow-up. I understand from representations from other organisations that work in your space and yourself that sometimes there can be a problem with you need a coordinating body such as yourself, but then there can be too much bureaucracy in that a referral goes to another hub and then another hub, possibly outside the region, and what could have possibly been a local organisation delivering services to local people ends up being a telehealth appointment in Sydney. Is that an issue that needs to be addressed?
It is, certainly, that we're seeing more and more that digital solutions are being offered as a way to reach everyone. We know I was down the road yesterday and I still couldn't connect to the internet. That gave me heart that you don't have to be 1,000 kilometres away to have bad connection problems, unfortunately, but digital is not always the answer. There are digital solutions that can be encompassed, but if we used a care navigator, and I'm sure social workers will also talk about this, if we used a triage or care navigator local model as part of Thriving Kids Solutions, they are connected within the community. If it was all the consideration was taking place locally, we have the potential to reach out to other services that are needed, but having that local understanding benefits families who are looking for services in the first place. And certainly, whatever the solution to thriving kids is, we would like to see regional application of that. There's not going to be a one-size-fits-all, roll it out, triage in one centre in the nation and send them out to a service. That is not the answer.
Yeah. And could I just add one thing? We're really keen that children get support with or without a diagnosis. So that was obviously the gateway into the NDIS, and will remain that for people outside thriving kids. But it's particularly this cohort, the developmental delay, for example, that you may never get a diagnosis, and that's not the issue. The issue is the support early to develop.
That's needed. Yeah,
yes, exactly.
We're very keen for that too. That it will depend on what the needs are rather than what the diagnosis is. Yeah.
If I may, Chair.
Sure.
Just on that, in terms of the funding, so there's been a bit of discussion already about the funding, but also the service model as well that's utilised in rolling out this initiative. Well, firstly, I agree that absolutely diagnosis should not be a gatekeeper in a sense to this, to engaging or to receiving preliminary supports at the very least. And in terms of the funding model, generally our thoughts were that an individualised funding model would be ideal because it supports, or more closely aligns in supporting choice and control for families. However, if choice and control can be embedded to a block funding model structure, as you've outlined as well, then that could be a path forward. One of the other things as well needing to consider in terms of the service model from our point of view is the continuity of care and how the funding model enables that or acts as a barrier to that too.
Yeah, well, I think many people have spoken about the need to have longer funding models and give certainty of employment, allow models to develop and community confidence in organisations. We would totally agree with that, and I think funding models can be mixed. You don't necessarily just have block funding and transactional funding, and they can be mixed.
Yes,
yeah.
Agree. Thank you.
Sam, any further questions?
No, thank you. I'm going to have to step back in. I just wanted to ask those questions, but thank you for your participation.
Good. Thanks for coming, Sam. Right, Monique.
Thank you. I'm wondering if you've got any suggestions for how we address the workforce shortages that we're hearing about in rural and regional settings across the board, really, medical and allied health.
I've just got one thing to say. I think Louise has got the longer answer, but actually my answer is the same as the previous question. So
just money.
5-year contracts would be amazing for this, because we are, you cannot train as an allied health professional. You can't do a degree in its entirety in our service delivery area. And so even for a new graduate, people have to relocate to take the job or come home, whatever it is. You can't offer that person a 12-month contract and expect that to be an attractive offer. But there's other answers too.
That's right. And I think this again is wider than Thriving Kids. The recent interim report from the Productivity Commission on the care economy has highlighted the importance of not looking at things like this. We could spend money in education and save money in health, and it mightn't be in one budget year, but it's possible. So if rural workforce, it may not seem obvious, but we could, if you look at the investment overall, if there was an incentive for people to relocate rurally and regionally, and they maybe received a discount to their HECS or education debt after a period of time, we are not expecting people to give up their lives. We would like them to come and have a rural experience for 12, 18 months. It would make a difference to all our children.
Good.
Prac placements?
Prac placements paid.
Do allied health professionals routinely undertake prac placements in rural and regional settings?
So we're fortunate in our area. We have a University Department of Rural Health, which is part of the University of Newcastle. They have a campus in Tamworth, and they have 4th-year allied health placements there. So people come for 1 year of their degree, that is, I think, part of the solution, and that's been positive. We take students, when it's not a paid placement, it's just extra work, which is positive. We want to be part of that, but it's working for free. There's not that many hours in the day.
Hard.
Exactly.
Yeah, that's right. Yeah. Agreed. But perhaps if we supported students in their prac placements, it would be a less stressful time for them, as well as an easier time for the people who are giving them the supervision during those periods. Yeah.
Good, thanks. We're also joined by Dr. Gordon Reid. No questions? Member for Robertson. Good. Ali, do you have any questions?
No, I just wanted to say thank you, Chair. Thank you to all of the people who have given us evidence today. It's been really great.
I've got a question. I think that wellbeing in reach nurse sounds really great. Located, consistent, really good contacts. And also just wondering what happens with social workers in that context. Is that something, do you think that would be needed? Having an in-reach nurse, but having how frequently are social workers embedded within the schools currently?
Well, we actually provided advice to this committee through notice that ARPA had given in one of the earlier hearings, just in relation to exactly that, what social workers' roles look like within school settings at the moment. And we are across really a diverse roles within school settings and contexts, and whether that's engaging or being contracted into schools or having paid positions as wellbeing counsellors or coordinators, or in other areas of school settings, social workers are there.
Do you have a comment on the wellbeing in reach nurses?
Just to add that, when we're talking about at-risk families for developmental delay and other disability, the nurses, I think, are a way of engaging that we don't really have elsewhere in the system. And so for that reason, and they also, so if there's a family that are known, they don't come to preschool, but the fourth sibling's going to start kindergarten next year. I think that being positioned as described, you don't start that conversation about developmental milestones, perhaps, nutrition or hygiene, or there's more fundamental issues. And I think that's the reason the engagement can happen there, where it's harder in other roles, in other parts of the system.
That's right, and I think the benefit of that nurse, in which we've had the recent exposure to, is similar to Healthwise. They're a professional who are being supported by a team and with professional development through their local health district or health service, just like the allied health professionals who work for Healthwise. For example, we provide a team environment. We're geographically dispersed, but we have a range of experienced allied health professionals within our organisation who work together with supervision and professional development. And while that may not matter to the family who seeks their service, it matters to the workforce development. You maintain a history of having experienced people in local communities, and when students come, there are experienced leaders there to pass on and keep that workflow going. So we know, Australian children are not rare minerals, but they're really important to the future of this nation. And so we need to make every effort to think about what we can do for their own happiness and for our prosperity as a nation. And while this inquiry has guidelines, things that we've mentioned could be changed in other facets of health to really improve the system overall.
Sure. I mean, rural areas have huge problems in the aged care space as well, which I'm sure you...
And we've seen how long it's taken to restructure that properly, and, well, the outcome's still to be seen. But I view this similarly. It's looking for structural change. It's not... There's very tight guidelines for this inquiry, but there is their capacity to do it properly and really help and change the lives of Australian children, whether they have a diagnosis or not.
May I ask just one follow-up question to Jennifer? Are the social workers in schools in rural and remote areas, are they there through the local health district as well, or how are they?
I actually, I may have to take that on notice. I don't have with me statistics or data around where exactly social workers are placed in terms of that context, but I'm happy to follow up and provide a response on that for you.
Thank you.
Do you have any questions? No. I've just got a couple of follow-up questions. The first is that we are concerned about a group of kids that miss out on intervention until quite late. And it does seem that, you know, if you come from a family that is a good advocate for you, you'll tend to get support. But there are people who don't. Does Healthwise do any sort of population screening or any sort of active exploration of which kids you need to be targeting and how you can get to support them early?
We actually have a really effective program called Primary Healthcare Nursing, which was funded by the PHN up until last year, and they looked at an alternative. But that was a team of experienced primary healthcare nurses who again entered community settings of all lifespans, but including schools, were trusted within the school environment, repeatedly visited small schools and towns, and entered, like Sally said, delivering oral hygiene, puberty talks, different things, and they became trusted, and they could identify children who would need additional support. And as we work as a multidisciplinary team within our organisation, they could be led to different services within our organisation and the town in general. We use everything available to us, but that either using a nurse, primary healthcare nurse, or a care navigator. I know other people have spoken about care navigation. It seems to be the answer, but it seems to be what's missing from every contract.
Yeah, well, that's true. And actually the community nurses and the child and family nurses have already given evidence to us. And they seem to be a workforce that is in rural and regional areas, is that right?
That's right, there are.
Yeah. Could I also try and answer your question? I think when you're a child and your advocate, your first possible outcome advocate, your parent or someone in your family, isn't able to be that for whatever reason, if you don't have somewhere to live, then advocating for your child's education is pretty far down the list of things that you have the resources to do. But in the absence of that, I think there are people in the local community, whether it's somebody who works at school who picks up the phone because they know the person that does the hearing tests and they know how to get that hearing test done, or they know that there's a big waiting list for a speech pathologist, but that there's a new paediatric clinic, whatever it is. I think that, people who know each other, who work in the same community, do pick up the phone, do work together and to advocate and to do what they can for that child. And so, that is where I think Thriving Kids investment there is where I think you can get the most value.
Yeah.
And that also takes away some of the pressure from GPs, who we know are so important in our whole team care, but are not the only solution. And similar to the point there that Sam raised, if by having that local connection, if Thriving Kids is I've identified a child with an issue, I'll fill in a form and it will go off to a national triage centre, the benefits of what we've just spoken about will be entirely lost. And when the unknown number rings the person, they're not going to get the response they need.
Well, rest assured that's not on our list of priorities.
Great.
Okay. Good. Any other questions? Good. All right. Well, look, thank you very much for coming along today, and thanks for all the work that you do. If you've been asked to provide any additional information, would you please forward it to the Secretary by the 14th of November 2025. You'll be sent a copy of the transcript of your evidence and will have an opportunity to request corrections to any transcription errors. And thanks once again for everything you do. And we will now suspend this meeting until 10:45, a short break. Thriving Kids inquiry, and I welcome people from Dietitians Australia and Exercise and Sports Science Australia. For the Hansard record, before giving evidence, could you please state your full names and the capacity in which you appear before the committee? Although the committee does not require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. Giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I will invite you to make a brief opening statement of no more than 5 minutes before we proceed to discussion. To assist with the transcription of the public hearing, it would be appreciated if you could please state your name before responding to each question. And I now invite you to make a brief opening statement. We might start with perhaps Dietitians Australia. Thank you.
Thank you.
Ms. Strathsworthy.
Thank you for the opportunity for Dietitians Australia today to present here. My name is Margrethe Raxworthy. I am the CEO of Dietitians Australia, the peak professional body and regulator for the dietetic profession in Australia. I'm here representing over 9,000 members. Neglecting nutrition in autistic children and children with developmental delays isn't just an oversight, it's a crisis in motion, in slow motion. Every missed meal, every untreated feeding challenge, every absent dietitian is a lost opportunity to support a child's cognitive development, behaviour and future. Nutrition isn't a luxury. It is a foundation for development. For children with autism and developmental delays, early access to tailored dietary support can mean the difference between thriving and struggling. These services don't just fill plates, they build capacity, fuel development, regulate behaviour, and prevent the silent consequences of nutrient deficiencies and faltering growth. Without these services, we risk failing the very children who need us most. We believe there are 4 critical interconnected elements that must be considered together to guarantee the success of the Thriving Kids program. These elements are effective best practice, multidisciplinary models of care, underpinned by robust funding systems and mechanisms that enable quality care delivered by a sustainable, well-distributed workforce operating at top of scope. I'd be more than happy to discuss this further when we open to questions. However, I would like to say that Dietitians Australia would be delighted to work very closely with this committee to design and co-design a system that can be sustainable for the future, that can last over time. And we are certainly keen to see that leveraging existing infrastructure and programs will avoid reinventing the wheel and help and assist Australians to access the right care. I also welcome with me Nicole Donnelly, who is an accredited practicing dietitian and would like to say a few words.
Thank you. Good morning, and thank you for the opportunity to appear before the committee. My name is Nicole Donnelly, and I am an accredited practicing dietitian and credentialed eating disorder clinician and a clinical supervisor with over 17 years' experience supporting children with disabilities. While I am here today as a clinician, I also bring lived experience of a disability which strengthens my understanding of the practical realities faced by families navigating these systems. Autistic children are around 5 times more likely to experience feeding challenges than their peers, often due to heightened sensory sensitivities that result in selective eating, food aversions, and restrictive diets. Children with developmental delays also experience feeding difficulties due to oral motor, swallowing, and gastrointestinal issues. These challenges can lead to faltering growth, nutrient deficiencies, disordered eating, and reduced functional capacity, all of which affect learning, energy, and participation. Dietitians play a pivotal role in multidisciplinary teams, assessing nutritional needs, recommending feeding modifications, and supporting families with practical evidence-based strategies to optimise growth and development. Group programs and parent educations alone cannot meet these children's needs. They require direct access to therapy funding for dietary supports and consumables to ensure safe, adequate nutrition and meaningful participation in everyday life. Early intervention is essential. Including accredited practicing dietitians in the Thriving Kids program is critical to delivering equitable, effective outcomes for all children. Thank you, and I look forward to your questions.
Thank you. Now, Exercise and Sport Science Australia. Would one of you like to make an opening statement?
Thank you, Chair, and thank you to the committee members for your time. Our submission number is 190. Briefly, Exercise and Sport Science Australia represents over 10,000 exercise physiologists, exercise scientists and sport scientists. Just under half our members, accredited exercise physiologists, work for or run their own business providing allied health services to NDIS participants. They are tertiary educated, professionally accredited. They are trusted and they cost effectively make a positive difference in the lives of so many of our most vulnerable. ESSA does not reject the premise of reform of NDIS. It was a world-leading social policy when Prime Minister Julia Gillard introduced the NDIS bill in November 2012. That's 13 years ago this month. The scheme has to be sustainable, but it doesn't have to be dismantled. If the government is going to denationalise the therapy support for under 9-year-old children with developmental delays, let's take the time to get it right and make sure the states are in a position to stand up the programs that won't leave these children left behind, disadvantaged for life and a greater burden on the acute healthcare system. In our submission, we have 5 recommendations we hope the committee will consider, but overarching that is our ask, our request that the committee and the government pause commencement of NDIS for another 12 months. That would be to the 1st of July 2027. For the sake of the NDIS, any future state programs, families and most of all the children, this transformation can't be rushed. I'd now like to introduce my colleague, Elise Hocking, Policy and Advocacy Manager, talk a bit more about the submission. Thank you.
Thank you. Good morning, Chair and members of the committee. Thank you for the opportunity to appear on behalf of ESSA into this important inquiry. I speak today on behalf of ESSA, but I am also a mother of a child with a global developmental delay and level 2 ASD. Early intervention is crucial for children with developmental, physical or functional challenges or delays. Getting timely access to clinical allied health support, including exercise physiology, is essential healthcare. In our submission, No Child Left Behind, we emphasise that a delay of even a few months can have serious consequences. Children risk missing key moments to grow and develop, falling behind in movement, cognitive, social skills, and facing greater reliance on support services that carry lasting impacts that affect their whole futures. ESSA's submission emphasises that when children and families must navigate a patchwork of state and territory systems with shifting eligibility, different service offerings and inconsistent allied health access, they face a real risk of being left behind. We risk undoing the very reason that the NDIS was established. Fragmented health and allied health pathways undermined early intervention in the past, and we cannot let that become our future. Exercise physiology must be recognised as a clinical intervention and not optional support. It helps children build function, mobility, fine and gross motor skills, prevents decline, and enables children to participate meaningfully in life, school, and community. Having a qualified and accessible allied health workforce ensures children get timely, evidence-based early intervention and reduces long wait times, because we know that every delay can cost a child their critical developmental window. Chair, I would now like to ask Eliza Smith, accredited exercise physiologist who works with hundreds of these children annually, if time permits, please. And thank you for your time.
Sure.
Thank you, Elise. Good morning, Chair and members of the committee. I'm Eliza Smith. I'm an exercise physiologist from Centre of Movement on the Gold Coast. During early childhood, particularly birth to 5 years, the brain is developing rapidly. It is highly sensitive to learning new skills and foundational skills. For children with developmental delays and differences, providing exercise interventions in this critical period has a profound and life-changing trajectory for these diagnoses. Within the past year, exercise physiologists across Australia have supported over 3,000 children with ASD and GDD through early intervention. This includes approximately 500 Aboriginal and Torres Strait Islander children. At Centre of Movement, we support these individuals through regular and intensive therapy interventions, mostly from our Gold Coast Clinic, but also through rural pop-up intensive programs. Every day I see what the evidence confirms, that movement-based interventions drive meaningful improvements in physical, cognitive and executive functioning. This has impacts on motor development, emotional regulation, arousal windows, social engagement, communication, among so many others. These gains matter. They are not abstract. For a child, something as simple as developing the ability to sit independently opens their world. They can engage with siblings and peers. They can play with more autonomy, feed more effectively, they can help more, do more, and they can improve their self-esteem and their comfort within their own body. Each skill then builds a foundation for the next. Because of its effectiveness, exercise physiologists have had the privilege of witnessing so many first steps, transitions, milestones met. Conversely, without early and consistent access to exercise physiology, children face a cascade of preventable challenges across a lifetime, some of which Elise just mentioned. Ensuring this early and streamlined access to exercise physiologists amongst other allied health professionals across all jurisdictions aligns with the Early Childhood Targeted Action Plan and is not only evidence-based, but it is essential to changing the trajectories of these diagnoses so that no child is left behind. Chair, I would like to hand over to Jess, the mother of a young boy who I have had the absolute privilege of supporting over the last year and a little bit for her family's lived experience.
Good.
Thank you, Eliza. Good morning, Chair and members of the committee. My name is Jessica Paolodi, and I'm the mother of a beautiful 2-year-old boy who has the current diagnosis of development delay, which, like many others, is being used as a placeholder while we continue to explore his formal diagnosis. Our journey began when Valentino was just a newborn. What we first believed to be neck tightness and feeding struggles slowly unfolded into a much more complex picture, one that has changed our lives forever. Navigating that reality and the process of advocating for the right supports was extremely overwhelming and isolating. But from 8 months of age, Valentino began regular exercise physiology sessions, and that decision has been transformative. When we first started therapy, Valentino struggled to hold his head up and control his trunk. This made it impossible for him to play and explore his surroundings. It was difficult to even hold him without providing full neck support. Over time, through consistent, targeted movement guided by his exercise physiologist, he's gained the strength and stability to engage more with the world, to reach, to look around, to play, and the confidence to begin to move. Recently, our smiley little boy learned to sit independently. Watching him achieve these milestones has been life-changing, not just for him, but for me as his mum and carer. It's given me hope, confidence, and reassurance that with exercise physiology, he can continue to get stronger, build function, and find more independence. These sessions have not only provided physical progress, but also emotional support. education, and a place to connect to other families that understand exactly what this journey is like. We live in a small country town on the New South Wales-Queensland border and travel 1.5 hours every week across straight lines to access these vital services. In our region, there isn't a paediatric allied health workforce. It is fundamental a postcode should never determine whether a child receives the support they desperately need during their most critical development years. Thank you for your time and commitment to hearing from families like ours.
Thank you. Well, we might open it up to questions. Monique, do you have any questions?
Thank you. Thanks, Ms. Paoloni. I think the personal stories are the ones that often sort of land them most strongly. Without being disrespectful, can I ask why an exercise physiologist, not a physiotherapist or an OT for your little boy? Why was it that you went there? I'm just interested about the process of it.
We access an OT as well, so we aren't just exercise physiology. However, from when Valentina was very small, as a mother that hadn't got any formal supports in place, I was just doing it alone, working with a paediatrician, trying to work out what was in our area. I stumbled across the Centre of Movement through the internet, and through there opened up the doors to exercise physiology. And just through our lived experience, the exercise physiology has proven the results. So once we started there and the consistent therapy started, I felt comfortable that this was the right choice. Yes, we do have elements of occupational therapy as well involved, and allied health, dietitians as well, but for the movement purpose, specifically for Valentino, the exercise physiology has been the foundation to build on feeding, to build the ability to sit upright so then you can have more vocalisation. It's the root for building on those other developmental milestones.
Okay, thank you. Two more questions if I could.
Speak more to that. Exercise physiologists do have a very unique background and training into movement-based interventions, which potentially other allied health don't have the same level of exposure to those movement interventions, as well as we work specifically with chronic conditions. So Valentino, when we first met him, was over that 6 months of age and had been presenting with a presentation that had been presenting for over 6 months, which puts it into that chronic category, which speaks to exercise physiology. However, we do, as Jess said, work with a collaborative approach. Myself and an occupational therapist work really closely together to make sure that Valentina's interventions are effective, evidence-based. We also reach out to the speech pathologist and et cetera to make sure that formulation of care is the best that it can be.
It's a real multidisciplinary team.
Yeah, thank you. Can I ask then, just to clarify this, so you had to resort to Google to find some help, essentially?
Yeah, that's the reality of a parent, because you don't know what the formal diagnosis of your child is.
Right.
It gets classed as global development delay, or they're just behind, they'll catch up. He's just not latching properly, it's a tongue tie, and it's not. It's a
But there
neurological...
wasn't an individual who could help you out and support you during that? I'm presuming your GP...
of course I had access to GPs and midwife and things like that, but nobody has a tool to diagnose it specifically as one or the other. You sort of sit and wait and you try to implement strategies to try and help just function. But yeah, there was nothing that diagnosed Valentino any which way other than obviously he wasn't meeting, a 6-month-old.
And that must have been incredibly stressful for you.
Oh my gosh,
and really,
it's life-changing. I think, incredibly stressful and emotionally, mentally taxing. It's on me as his mother to advocate and to give the ability for him to have a quality of life. And so trying to find the resources and the supports to help you in that, is a struggle. So access is so important, and supports, So, we can't allow any extra hurdles that these families need to cross to even just reach the bare minimum. Of,
Agreed.
yeah,
One more, if I may, Chair. I know Ailey's got a hand up. Could I just ask the exercise physiologist, just to clarify? So it's my understanding that there's an ongoing and persisting issue with remuneration of sports physiologists. And the funding model for your particular branch of allied health, would you be able to just give us some information around that?
Yeah, just quickly, under the NDIS fee review, we've been frozen. I think we're up to year 7 now. We haven't had the reductions that some other professions have had, so that's some good thing, I guess. That's probably because our fees are generally more aligned between the private sector and the compensable scheme. So outside of that, we've also had a Fair Work Commission review that's coming to conclusion probably this month or next month, where the commissioners have looked at the fees across our ward, and this was in the context of a gender undervaluation. And Fair Work Commission has handed down interim decision, so that's going to see reasonably significant increases, particularly for the entry-level AEPs, and so that is not one of our issues in that submission we put in. Is they're not necessarily aligned. They're not aligned with fees in the compensable schemes. Doesn't matter if it's NDIS or DVA or the state workers' compensation scheme. So there's going to be a little bit of pressure there, but it's also, we think, we back what the Fair Work Commission have said, that our professions go through 4-year degrees. They're getting that recognition now, we believe. But yes, it's certainly put pressure to have that freeze for 7 odd years. In our response to the NDIA fee review, we recommended that they have a 3-year cycle. So instead of going every year, you have this argy-bargy. Organisations like ours devote a lot of time and energy into confronting that and putting in submissions and things. So we recommended, like other places, have a 3-year cycle where you maybe lock it into 2 years of CPI, and then the 3rd year you do a structural review again. So that's another issue, I guess.
Thank you very much. Thanks, Chair.
Good. We had a similar issue in our previous inquiry into diabetes with the compensation for exercise physiologists. It still hasn't been resolved, I don't think. Yeah. Sorry, Ali.
Hi everyone. Sorry if you can hear my dog snoring in the background, but she's very old and I don't want to move her. I don't think she's got long to go, so she's just in the background. Thank you all for appearing today. I really, really appreciate it. In particular, thank you, Jess. I really resonate with your story. My son had a rare genetic disorder, so I had the benefit of a multidisciplinary team at age 1 and then after age 3, and went through a lot of issues regarding getting him walking again and having good movement. But what I wanted to say, it was I guess in hearing your story, which I think is incredibly important. For me, one of the big issues with this inquiry is addressing the huge gap in the NDIS at the moment and in services in general across Australia for families in regional and rural areas, and particularly families who don't have the opportunity to get on the internet or don't have the capacity to get on the internet, but also don't have the capacity to drive to a service. Or do you have any comment about, Jess, about your region and about other families in the region and how they might experience services in the region?
I mean, like, how do they access them? Is that what do you mean? Yeah. I think they go without, as sad as that is, unless they're in like an acute setting, which is in the hospital, I guess. But apart from an acute situation, they don't have access. They simply do not. Having the health literacy or the capacity to know where to reach out and find those supports is a real fundamental issue. And then once you do, you then have to then commit your time, your own ability to physically get there is a huge struggle. And a lot of these children suffer multiple medical issues, whether that be sensory or whether you've got seizures. We've got all sorts of things. So making the travel even far is so hard, but you just really want to give them that chance, and you want to access these vital services that provide that to their life.
So do you support a more local services, more, having a boost of local services? You have the ability to make choices and have the ability to make that drive, but do you, for families?
Yeah, it would definitely make it easier, but that's why, having like a national integrated system that allows, no matter where you live and your postcode lottery, you can still access that child's individual needs, whether that be, exercise physiology and allied health. You have that choice. But making it more local is obviously easier. However, the workforce isn't everywhere in every town, everything. That's why we have these models, the pop-ups and things like that allow those communities that are a bit further away to still access these life-changing services.
Okay, well, thank you so much for that. I appreciate it. I've only got one more question, but it's more of a, not for you, Jess, for Exercise and Sports Science Australia. In the opening statement, I'm a person with a disability. I speak to people with a disability every single day. I rely on the NDIS. I personally don't accept that. I want to see reform of the NDIS. So I think the opening statement said that ESSA does not accept reform of the NDIS. Most of the people in the NDIS, my friends, significant disabilities, want to see reform of the NDIS. We have a situation in Australia where the states have pulled out of a lot of services, leaving a lot of people in regional and rural areas. No matter how big their budget is, they cannot get services. We can't have a two-tier system where some people are able to access services and others are not. I do not want to see the kind of rorting and situations with the NDIS where, and I've had many examples through my office, I want a sustainable NDIS that lasts right into the future. I also want to see with Thriving Kids the opportunity for kids who require the NDIS to still be able to be on the NDIS but also access Thriving Kids, but also if they need later on to get onto the NDIS that there's an access pathway for that. But I don't accept that the NDIS does not need reform. So I don't know whether the chair or the CEO of Exercise Sports Science Australia just wants to respond to that. Sure. For me, as a person with a disability, I want to see reform.
Yeah. Can I respond, Chair? Yep. Look, sorry if it didn't come through properly, but I said we do recognise there needs to be reform of NDIS, and I think you mentioned a few features there, including some of the rorting that might have gone on in the past. I'd just like to reiterate that I think there is very strong support for it as a fantastic social policy. It's delivered a lot of good. Yes, like every large program, it's always up for improvement. Our theme or our suggestion was to hasten slowly with this one. It is a big transformation. NDIS came into being. I think many of us in this room are probably around as it was developed in 2011, 2012, 2013, those sorts, and it was developed for the reasons that there was fragmentation and patchwork of services and those sorts of things. We've had the opportunity to talk to state health and education ministers. They're scrambling. Their ability to stand up programs is, in their mind, is in some doubt. I guess that's for them to say. So again, very much just like to say that we're not against change and reform. It can always be done better, but I think maybe like aged care, just hastens hasten a little bit more slowly and get a really good program. It might take another 12 months, stand it up on the 1st of July 27, and that'll give everybody the opportunity to have a better system. I'll just finish very quickly a bit along those themes that Jess was talking about. It's been put to us that there's intergovernmental agreements between, let's say, New South Wales and Queensland in Jess's instance, and that will take care of everything. But those intergovernmental agreements are around the acute care. So there's question marks in our mind. If we go back to state and territory systems, there's no, at this stage, no intergovernmental agreements on things like allied health. Will people like Jess be disadvantaged by living in Murwillumbah, then having to apply somehow to participate in a Queensland scheme? So I think there's some unknowns around those sorts of things. Let's get the intergovernmental agreements right, and say if that takes a little bit more time, I think that'd be worthwhile.
Just to finish up there, thank you for that comment. I appreciate it, and I agree that reform is needed. I think that waiting 12 months for some of these kids in regional and rural areas is too long, personally, for me. I don't think that 12 months can make an enormous difference where they're getting no services in many areas at the moment. And so kicking the can down the road, I think personally for me, the states have known that this is coming for some time. But yeah, I appreciate all of your comments, that reform is hard and that, we need to get it right. I absolutely agree with that. We do need to get it right. I think it's incredibly important. But thank you for your contribution. I really, really do appreciate it.
Thank you. Thanks, Ellie. Sophie.
Oh, thank you. I've got questions for both dietitians and exercise physiologists. Ms. Paolini, I had a question for you because you're obviously highly articulate and motivated, and but still have to do your own research to find the services, and that's a difficult time, particularly with the emotional load that's going on at that same time. What would you like to have seen in that moment, in that kind of transition time before you got access to care? Sounds like you had your GP there, but they're not always as tied in, or able to provide that advice about what services are specifically where.
That's exactly what I needed, somebody to be able to facilitate that, someone where we can turn to get this help. Mm-hmm. It doesn't exist in those early stages. You have to wait for so long before you can access something like that. And that is the hardest thing. Yeah, it takes a lot on the parent and the carer to just do it yourself. That's what I needed. I needed somebody to sit there and go, okay, these are your options, these are your supports in your area or close by. Let us navigate how you can either fund that or bridge that gap to get the support that Valentino definitely needed, just to even feed. We could not feed him. He could not swallow. So, how do you,
Incredibly stressful.
Yeah, incredibly.
Well done.
And, very unexpected. It's not, no one, expects that when you have your first child or any child. We just really needed that support somewhere in those early days where you don't need that formal diagnosis. You don't need X amount of months of showing that there's something. You just know there's something not right, and you need that support of someone to listen and connect you to those services.
Thank you. I have a question for Dietitians Australia. I just was reading one of your key recommendations. So you have 70 recommendations, but one of them is something that I grapple a lot with, and that is around the avoided costs. And just wondered what evidence you have. You said that there's preventive nutrition measures deliver returns over 5 to 10 years, for all sorts of different reasons. And it's really difficult when you've got saved costs through prevention, but it's always very, very hard to account for that. Have you got evidence for that, those type of savings?
Sorry, before we speak to that, can I make a comment to extend on what we were just talking about? So as I said, I'm a clinician. I'm also a mother of a child with a disability, and I went through a very similar situation with my son, who's now 10. And I was, I guess, in a privileged position that at the time I was working at ADIC, which is Ageing, Disability and Home Care, the statewide New South Wales Disability Health Service before NDIS. And so I was keenly aware that my child had a developmental delay, and I was able to access services and knew where to go and all of that sort of a thing. And now I see that that service is no longer available. So what I would like to see is a mixed model of funding and including allied health being able to do those initial assessments and interventions and be able to then refer on to other services as needed, because that really helped me and my son. And, you know, he's doing really well now. Certainly I want to see that be available for the children and the families that are now in that 0 to 8 category.
Yeah. Thank you. Yeah.
I will just come back to your question about the evidence.
That's okay.
So I would have to take that one on notice, so I don't have all that details and the data with me, but we do have data that we can share, and we certainly welcome the question and will be willing to share that.
It's a real difficulty, isn't it, when you have to account for those avoided costs? And I just will ask one question, because it was really good to have the reminder about how important nutritional screening and support is in that development. How often are dietitians involved within those multidisciplinary care teams? Is it common?
Yeah, absolutely. We have many models of care that we could present today if you're interested, or we can send it through to you later. One of them, the Healthy Kids Bus Stop, was presented by the first presenter today, and we think that that would be a wonderful model of care that absolutely could be scaled and rolled out across all of Australia. And those allied health practitioners, any of them, any allied health professional, can do the initial screening and assessment and then refer on to further services.
Great.
Maybe just to add to that, I think the most underpinning factor here is the funding and how the funding intersects with NDIS, how the programs intersect. Another critical factor is in that funding mechanism is the sustainability of the workforce. How do we attract the workforce, but we also retain them, not just into rural and remote communities, but across Australia. We know that recent changes and recent cuts to funding, and dietitians had a cut to their funding during the recent funding amendments for NDIS services, and that has made the community extremely anxious, but it's also made the workforce extremely anxious. And some of that workforce already indicated to us that up to 2/3 of them are looking to leave the sector because it is no longer sustainable. And so I think a very critical factor in our design needs to really think about how do we attract that workforce but keep them and retain them, because they really do want to be there. They really enjoy that work. They enjoy supporting these families, and they enjoy seeing the outcomes of their work. I think the interoperability of these systems is vital. The digital components is critical to consider. There's the communication aspects. There's a lot of case conferencing that happens with allied health professionals, together with doctors, paediatricians, nurses, across those professions. But case conferencing can only be effectively supported if we have the digital systems that underpin that, and we have the ability to be able to document the interventions. So I think that's a very pivotal piece of consideration as part of the design that we're considering. For the allied health professions and for dietitians specifically, ongoing supervision is really important. So when we are sending new graduates into areas, because that is what we have to work with, because we have an expanding need and of course a workforce, we do actively encourage that there is supervision in place for those new graduates. We want quality of care, But quality of care cannot just be guaranteed by constantly recruiting the most experienced people into the workforce. We need to sustain the workforce development and their career progression in this sector too, and that can be done effectively by ensuring that there's effective supervision in place.
Can I just ask, when you say effective supervision, you mean digital supervision? So if there's a young graduate that goes remotely, then they have that digital supervision?
Absolutely, and you've seen that. You've seen some of our colleagues present earlier today as well, talking about supervision and how more experienced clinicians can, via digital means, still provide an effective way of supervising those graduates in their context as well.
I provide clinical supervision to many early career dietitians, both individual and in groups, and it's a very effective way to ensure the quality and safeguards of the service, and that can be done across all of the allied health professions.
Right. Move on, Ms. Stanley.
Have any of you turned your mind to how we ensure the quality of the services you provide? And because one of the criticisms that comes through my office with NDIS participants, and the participants we're talking about for Thriving Kids are even more vulnerable because they don't yet have that diagnosis or those other, paediatric sort of wraparounds, is that people set up their shingle, they can do whatever they purport as an exercise physiologist or a dietitian. They purport that they've got these skills. How can someone like Ms. Palloni, and thank you so much for coming today, because I think we all recognise in your situation this is very difficult to talk about continually, so really appreciate your insight. That parents are not sent down the garden path and lose 12 months perhaps of someone who doesn't have the skills or is not willing to hand them off when they realise that what they initially thought they could help with is not what the issue is for that particular person, and they actually need something else. Like it's the exercise is not cutting the mustard because there's another problem, or that other problem has to be sorted before they can come back to you. Have you, as heads of your organisations, thought about how we put some rigour around this?
Absolutely. So, Marguerite Raxworthy from Dietitians Australia, I can respond to that. We have quite significant CPD programs in place for dietitians, particularly focused on the disability sector. For the last 2 years, we have been operating a program building capability for dietitians in the disability sector. And that is an effective program that operates with a grant from the Department of Social Services. These programs are vital to continue to build new graduate understanding and also skill sets to operate within the sector. Supervision is a best practice in the health sector. And so it is also something that we actively invest in as Dietitians Australia to absolutely encourage our new graduates to undertake. So paired with a more experienced clinician like Nicole, to be able to develop their practice, to navigate blind spots, but most effectively to provide effective and quality care to those that depend on them.
So I need a dietitian. Can I go to your website and get a recommendation of people who have done your programs and succeeded? And is there some way that you make sure that if someone is not as good as they should be, they are no longer on your recommended list?
So we have an annual audit of our accredited practicing dietitians. They have to complete 30 hours of CPD per year. Of course, one thing feeds the other. So I talked about funding mechanisms earlier. We have to provide an attractive sector for people to enter into. Once that happens, people flow into that sector and the capability building happens. Without guaranteed funding and it being sustainable over time, and that includes adequate remuneration for clinicians, you can imagine that you will never end up with a skilled workforce that will sustain in the sector. So we do have mechanisms in place to be able to adequately control the quality output and the standards that we expect of accredited practicing dietitians, but without the sector actually supporting good funding mechanisms for those dietitians to flourish as a career in the disability sector, we're going to have an ongoing mechanism where we're not feeding people into that sector.
Thank you.
I'll ask you.
Answer that question
Sure.
as well. So at least from Exercise and Sports Science Australia, we have a similar model in regards to accreditation, regulation, CPD, that's all very akin there. We do have a list of accredited exercise physiologists that we share with the compensable scheme. So in a case where somebody has been suspended for a reason, or if there's been concerns raised while they're undergoing a process, we share that name with the NDIA, for example, in this context. We meet with the NDIA regularly where we share data and trends, and there may be concerns of things like over-servicing, which is, I think, what you're talking about a little bit there as well, where we will then work as a peak to ensure that we're responding to that need. So whether it's education to members, additional training, changes to our processes that members have to undertake. So we address those quite regularly informally with our members, but if there's a specific issue raised that needs to be dealt with more formally, it can change things like our code of conduct that members have to work under. It can change things where it can go through a committee that we have internally that might recommend that a particular CPD module becomes mandatory to be able to work with these NDIS participants, for example, and they're things that we work on all the time and rely on that data, and we really try to respond to that. Our members also do objective outcome measures at different intervals with the children and families that they're working with to ensure that they are delivering the goals and objectives that the children came to them with. So we do pre and post, reports and assessments. And this is where the pop-up model comes in as well, that maybe Eliza might be best placed to speak to. But we work to support the families and to upskill them, and a big part of an exercise physiologist role is to increase the health literacy of these families to be able to navigate systems, and also working in multidisciplinary teams to make sure that we don't think that we're the only profession that can achieve these things. We work together really closely with other allied health professionals, with GPs, with paediatricians, to make sure that they're linked in at a time that they need it, to make sure that the whole child is being considered. And I think, Jess, and, we've had a couple of parents here, and we all have high health literacy, and it is a taxing and at times impossible journey, and we know what we need. Yeah. And so, my concern is always, and the reason I got into the policy and advocacy world is because I struggled as somebody who has extremely high health literacy, who works in this sector, and still took years of, I've made over 745 phone calls to access the supports that my child needed. Yeah. And not everybody can do that. Not everybody knows what exists. And so this is my concern, and this is where the allied health workforce comes in, is that connection piece while we're on wait lists for paediatricians that, depending on where you live, can be years. It is years. And so we're integral in that regard to make sure that they are actually knowing what's available and helping them navigate that system.
Thank you very much.
Yeah.
Thanks, Chair.
Thanks. I just wanted to ask a couple of questions, and Ms. Paolini in particular to you. There seem to be roadblocks all along the way. Was there any way or any group that you saw, or person you saw at the beginning of your journey that helped you along the way? I'm talking about the child and family nurse. No, apart from the exercise physiologist.
Honestly, that was the turning point.
But what about the child and family nurse? Did you go to the baby health clinic?
Yes, I went to them. It was very much a sit and wait situation. They weren't skilled to help with an extremely difficult feeding
so you had problems
struggle.
with breastfeeding?
Yeah, even bottle feeding. Couldn't swallow. So that positioning with a bottle, you had to hold him down and position him like this. It's such a...
What about your GP?
GP, similar again. Sit and wait was probably what is the reoccurring theme that I had. It was like a wait and see.
Were you referred to a paediatrician earlier?
I was on the wait list. It took over 9 months for me to see a paediatrician.
Wow.
And that was not from a lack of trying. My GP did write numerous referrals. But like I said, it was down to a torticollis, a tightened neck, was all the data we had, all that we could put it down to, and feeding struggles. So you're not scaled up onto a high triage. Yeah, we're not triaged.
Was he gaining weight or?
Not really. No, he was just sort of the same. He was I think he was in the 2%.
Right.
Yeah.
Okay.
So yeah, and then obviously there's an acute setting where you get put into hospital, and I actually went to hospital when he was 8 weeks old for 24 hours, and purple cry syndrome, I think it's called, something like that, was what it was put down to. So it was just a child crying and inconsolable for feeding, can't tolerate the formula, cow's milk allergy. No.
So there were multiple.
Yeah, so it wasn't from a lack of trying, and it was like I tried all the services that are available to you in the community, and everyone trying their best, to give credit,
sure.
Everyone's doing the best with the knowledge and the resources they have, but this isn't a typical child, so you don't see it every day, and so they're not trained in that specific
And how's he
thing.
going now?
He's made immense progress. Still feeding is still a huge challenge, and physically, but
He's
a lot better.
two now, is that right?
He's just turned 2 in September. Yeah.
Is he mobile?
He can sit. So we're not, we're trying to transition now from sitting to 4-point to try and get to that crawling.
Yeah.
The world's his oyster, and with the continued efforts of our team, I hope that you can. Yeah.
Did it cost you a lot of money at the beginning?
Yes, we privately paid for Eliza, and obviously I wasn't able to return to work. I couldn't leave my child with anyone. He wasn't able to be fed by me, let alone anybody else. Along with that, he was in immense discomfort. So I still have not returned to work. I cannot leave my son. He can't access daycare and things like that because there's not that support there. So it has a massive effect financially too, which I don't think we've touched on, just for those families. And
I mean, there's so many different roadblocks.
The roadblocks are endless. But the pivotal point was
seeing an allied health.
Yeah, going to the allied health, and that opened that community to the OT. That opened up. Eliza has seen similar situations, so she was able to help me navigate. What supports I needed and what questions to ask to get to the neurologist, to get all these things to help with further diagnosis. Yeah.
So you're seeing a paediatric neurologist now?
Yes, now we do. Yes.
Right. And when did you first get NDIS funding?
Valentino was after we started seeing Eliza, so he was almost 10 to 11 months of age. Yeah.
Right.
Yeah, it was about 11 months. Yeah. He was almost 1. Yeah. We started to get some funding, and it was very minimal because it was just obviously very, very minimal, but it then helped us to have continued therapy, weekly sessions at least. So I am grateful for that. But it did take a long time to get there, and still recovering from those early times for sure.
Yeah.
And I still get presented with roadblocks, even though we do have more supports now than we we did at the start. It's never ending, the roadblocks, yeah.
What's the latest roadblock?
Access to assistive technology. So, yeah, how does he sit in a chair? Yeah, you need the lateral support. Just finding the time and the capacity and the funds to write that and to submit that to then get, Yeah, good. I could go on, but
And as I think we've acknowledged, Jess is an extremely intuitive and a mother and has a really high health literacy, and as we've
very
noticed,
articulate too.
Yeah,
So.
we not everyone is in that position, and we do note that global developmental delay is used as a placeholder, as Jess said before, for a lot of more severe and lifelong conditions. Up to 20% of those come down to chromosomal abnormalities, and then genetic disorders, when these diagnoses are finally found, is almost up to 50% of those. Just in the last fortnight, I've had a 3-year-old and a 17-year-old find their rare genetic diagnoses,
We're keen to not make it diagnosis dependent, but needs to dependent. Yeah,
absolutely.
Good. All right, well, look.
Can I ask one final
Sure,
question?
sorry.
Have you still got questions? Or
No,
to finish off?
No, up to you.
I just wondered, it seemed like you had a number of touch points with the health system. Your child was in hospital, you saw the GP, you saw the child and family nurse. Were you referred to allied health services? It sounds like you dug through and found your own where you needed to go. Were you referred to allied health, notably dietitians?
In the acute setting, obviously, a dietitian was involved when a feeding tube was placed very early on. So, of course, the hospital in an acute setting has a dietitian. In saying that, my local hospital doesn't have any service to provide anything with a gastrostomy, so a feeding button in the stomach, which Valentino now has. So they can't even provide me support with how to do blended feeding, so you feed through the gastrostomy. But in the initial stages, no, other than that, in that acute setting, there was no, here's, allied health supports in your local area. It was more when you've got NDIS funding, you need to go find those supports. Okay, the internet comes into play. Your health literacy comes into play. That's not, you don't want to disadvantage those children that don't have a parent that has that capability. So, and I see families, at the Centre of Movement, that's connected me with families on a similar journey to ours, and there's a wide variety of differences in what people are accessing just purely to what they know.
And it was a whole new world as well.
Oh, you're navigating a whole new world. And yes, but allied health wasn't, other than in that acute setting, it's then not set up to help you navigate that path to reach the people you most critically need for your child. Yeah.
May I also make a comment on that as a dietitian?
Sure.
So, dietitians, it would have been wonderful to be able to provide that service in the community for your son, like we do in other areas, and involving dietitians in addressing feeding disorders in children in just this one study resulted in improvements in energy intake from 78% to 123% of their recommended dietary intake. They had significant gains in weight and height Z scores, increase in skin fold thickness, and reduction in feeding-related hospitalisations from 0.4 to 0.15 admissions per patient year. And that's just one example. So, rolling out that, allied health workforce would be able to prevent and improve those case studies, for those children. And importantly, what we know from the evidence is that when dietitians are involved early on and the child is able to receive adequate energy and protein intake, that they then make more effective gains in other therapies such as exercise physiology, physiotherapy, occupational, and etc., because they then have the energy and the stamina to be able to participate in the therapy to then get the gains from those. Yeah.
I'm conscious we
need to
move on because of time. Ellie, did you have another question? Your hand's still up.
Just quickly, I'm interested in the diagnosis commentary from Jess. I think we've all been talking about getting early supports without diagnosis, and I know for my son he didn't get diagnosed till he was 3.5, and that completely changed everything. And I think it basically kept him alive for the next few years. We had a completely different response in the acute hospitals. We had a different response in every single setting. I think it created a pathway, the diagnosis, but I do think that there are I think there are developmental delays that lead to significant diagnoses, and then I think probably there are, in other people's circumstances, unlike ours, developmental delays that are going to be steady as she go, and a diagnosis. I actually don't think that we could have got a diagnosis earlier than 3.5. I don't think it was, despite everyone's best attempts. Did you appreciate the support without the diagnosis? Like, do you know what I mean? Like, can you talk to me about the timeframes between, what happened between diagnosis and then between noticing that there were issues and the supports you got to diagnosis, and whether that was beneficial, or do you think there should be some sort of pathway where diagnosis is a priority? I don't know if that's too confusing.
No, I kind of get what you're saying, yeah. So obviously, we still don't have a formal diagnosis. We have spent over $1,000 on genetic testing. We have done all the pathways available through neurology, through GP, through paediatrician, all those things. So we have, similar to yourself, you do everything you can, and despite everyone's best efforts, you don't know what it is. It can be rare, it can be just something that you may never know why as well. I mean, I think the stats are that, diagnoses are usually between 3 to 7 years of age, which, you're getting into that real fine line of being out of that critical early intervention window then of providing the care that they need to develop those milestones and things. But yeah, I think there probably needs to be a priority in certain circumstances, so some sort of system that can help scale that to say, well, this child, isn't meeting X, Y, Z. Their priority of diagnosis, of trying to find a diagnosis, needs to be pushed, or because a lot of the times they wait to do genetic testing because they don't see the urgency. But having a diagnosis, I think, in some terms would help people respond to you better, unfortunately, and that's just the reality. It gives you that title that then people go, oh, this is serious, okay, we need to, give you the funding or give you the access to more therapy or whatever it may be.
Perhaps if I can interrupt, diagnosis sometimes is important because sometimes these are treatable conditions, number one. Number two, it gives you some idea of prognosis as well.
Yeah, I think that's the biggest thing I live with. I don't know Valentino's prognosis. I don't know what the trajectory is going to look like. And if we knew what was the root cause, we might have some idea of people that have lived it or what the further health implications that might come. Yeah, and we don't know that. So you live in fear and of the unknown.
So we're going to have...
Sorry. Or an unknown treatment, 100%.
You're missing out on something
that you don't know, 100%, and that's where you spend a lot of time researching.
Chair, I was just going to say, if the committee members have got time, we have sent round, and we'll send it round again, a very short video that shows Valentino. So you'll get to watch Valentino and get to watch that therapy. So it's on YouTube. We'll send it around again.
That'd be great.
Thank you.
And look, I'm sorry, there's lots more we could ask, but unfortunately we are well over time. And look, I thank you all for your very valuable time, and in particular, Ms. Paolini, I know it's really hard talking about your own personal circumstances,
to be here, so thank
but
you.
we could have had a more articulate witness, so thank you so much for coming today, and all of you really for the effort you put in. We really do appreciate it. We understand the importance of what we're doing. We do really all think it's important. Every member of the committee is very engaged. And we did take on board that the timeframes are relatively short. We do think that part of our report will include the ability to review whatever changes are made over time. And once again, thank you for coming. If you've been asked to provide any additional information, could you please forward it to the Secretary by the 14th of November? You'll be sent a copy of the transcript of your evidence. We'll have an opportunity to request corrections to any transcription errors, so thank you so much. And I'm sorry we've gone a bit over time. I'd now like to call witnesses from Uniting, New South Wales and ACT, and online the Smith family. Sorry, guys. So I welcome witnesses, as I said, from the Smith family and from Uniting New South Wales ACT. For the Hansard record, before giving evidence, could you please state your full names and the capacity in which you appear before the committee? Although the committee doesn't require you to give evidence under oath, I should advise you this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'd now invite you to make a brief opening statement, and also to assist with the transcription of the public hearing. It'd be appreciated if you could state your name before responding to each question. I now might ask the representative of the Smith family to make a brief, underlined brief, opening statement. That would be great. Thank you.
Good morning, Chair and committee members. I'd just like to acknowledge that we're here on the lands of the Gadigal people of the Eora Nation, and thank you for the opportunity to appear before you today. I'm Wendy Field, and I'm the Head of Evidence and Impact at the Smith family, and my colleague, Sulabha.
Hi, I'm Sulabha. I'm the Group Manager for Programs and Strategic Initiatives.
Thanks.
As you might know, the Smith family is a national children's education charity supporting young Australians experiencing disadvantage. We've really welcomed the Thriving Kids initiative and commend the committee for its focus on equity and inclusion and early intervention. Our submission draws on our experience over many years of working with families through our long-term Learning for Life program, and particularly our more intensive On Par pilot program, which supports families facing very complex and compounding challenges. So in terms of our reach, in 24-25, we reached over 186,000 children and young people across 91 communities. And I think these numbers reflect both the scale and of the need and opportunity to make a meaningful difference. What we'd say is that family circumstances for a whole range of families, such as single parenthood, health or disability challenges, and low socioeconomic status, significantly impact children's educational outcomes. So in Learning for Life, nearly 60% of students live in single-parent households and 40% experience health or disability challenges. And those families often face additional barriers such as limited digital access, lower parental education attainment, and reduced workforce participation. So we strongly support the initiative's intent and believe it represents a really unique opportunity to embed a system-level response that's inclusive, responsive, and grounded in evidence. We advocate for a model based on progressive universalism, where all children benefit from high-quality services and those facing the greatest challenges receive additional support. So our submission outlines 3 key design principles, so strengthen universal services, national policy, so clear evidence-based with local adaptation, and empowering parents. Our experience really shows that parents want the best outcomes for their kids. They often don't know how to access the support that we need. Through our On Par pilot, we've seen firsthand the impact of family-led, strengths-based case management, so a navigator and coach in the system. Families report improved school attendance, engagement and well-being, but they also share their stories of long wait lists, fragmented services and the emotional toll of navigating complex systems. And our submission has many quotes from families around the roadblocks, as you termed them, that they have experienced. And those stories are not isolated. They reflect systemic gaps that Thriving Kids can help to address if it's designed with families at the centre and delivered through trusted universal platforms. Just to frame our input, we're not a service provider. We're not a national disability insurance service provider. We're not specialist medical providers. What we bring is the voice of our families and the challenge in the current system that those families have faced. We're keen to support the design of this initiative and to bring our families to the front in this.
Thank you very much.
Thank you.
Uniting, would you like to make an opening statement?
Yes, please. Thank you to the Standing Committee for inviting us to speak about the Thriving Kids initiative today. Before we begin, I'd like to acknowledge the traditional custodians of the Canberra area and pay my respect to elders past and present of all Indigenous peoples. I'm Claire Lawrence. I'm a Principal Policy Officer at Uniting New South Wales ACT.
Good morning, Chair and Committee. I'm Lisa Kinsey-Smith. I'm the Head of Operations in our Disability Services and our Child, Youth and Family Services in a region in New South Wales.
So Uniting New South Wales ACT is the social services and advocacy arm of the Synod of the Uniting Church in New South Wales and the ACT. We support over 156,000 people at all stages of life, and that's across a wide range of services, from our early learning child and family services to disability-specific services such as local area coordination and mental health. We see every day how early intervention is one of the most effective tools that can change children's lives. As a community, we need to think flexibly about what early intervention looks like, how it is delivered, and how it can be embedded in places and spaces that children and families already access. All children and families should have the right to services which allow them to thrive, but too often those who need support the most are missing out. Complicated systems, inadequate services, and a lack of cultural safety all create barriers to effective early intervention. Thriving Kids represents the opportunity to establish a nationally consistent right to early intervention, regardless of circumstances or location. However, this shouldn't mean a one-size-fits-all approach. As a not-for-profit organisation that provides early intervention services and community services across the care sector, we see firsthand how services vary according to the needs of their communities. The diversity of our children, families and communities means that our services in Kempsey are delivered differently to the services we deliver in Western Sydney. There are already examples across the care sector where providers and communities are working together to deliver supports which respond to the unique needs of children and families. This can include child and family hubs, navigation and peer learning programs which work collaboratively with mainstream systems. The opportunity for government is to establish effective funding structures, provide targeted investment which meets the specific needs of communities, and flexibility for communities to co-design and deliver their own services, ensuring that good services and existing systems are better integrated and utilised. Thriving Kids should be built on the principles of equity, accessibility and flexibility. A nationally consistent approach should be delivered through programs and initiatives that must be based on the specific needs of those communities, including First Nations, culturally and linguistically diverse, and regional and remote communities. We welcome the opportunity to share our experience with the committee today.
Thank you. Monique, would you like to go first? No? Anne?
No, not right at the second, sorry.
Okay.
It's been a very long fortnight.
I might just start by asking the Smith family, and clearly the Smith family has a long track record of supporting kids from very disadvantaged backgrounds. Do you work in rural and regional areas as well? I think you do, but yeah.
We work in some regional areas and some rural areas. We don't work in remote areas. I'd say our major footprint is in the, outer metro into the rings.
Yeah, I mean, outer metropolitan areas are quite disadvantaged in many cases. There seems to be a bit of a disconnect with the NDIS to me, this is my personal view, in that people who are very articulate are much more likely to get better services than those that aren't health literate and aren't articulate. How do we approach that inequity? Do you have any thoughts on that?
I think, our take would be, as we've said in our submission, that families really struggle, and we heard through the previous speaker, really struggling to find the support that you need. I think our observation would be that the current system really pushes families to an assessment and then a diagnosis in order to release support. And in many instances, there are long waiting lists, A, for the assessment and B, to release support. And then in some instances, the support that they need is not available in the communities that they're in. So I think, our observation would be that quite often if schools or early childhood centres were appropriately resourced to deal with some of the children who have behavioural challenges, or to work with parents around practices that they might be able to use to support their children's development, you could remove the necessity for some families to go down the diagnosis path.
Yeah.
So in our On Par program in particular, and I might get Sulapa to speak to this, the barrier of assessment and diagnosis has been a significant challenge, to the point where one of our private funders has been funding the assessment process in order to unlock support for those families. So I might ask you to speak.
Where was that again, did you say?
It's a pilot program that we're running in Mount Druitt and Onkaparinga in South Australia.
Okay, good. Right. Would you, before that, perhaps would Uniting like to comment on that as well?
Yeah, we can absolutely agree with the Smith family's experience around that. We would comment around the financial disadvantaged families, and that in our experience, trying to find those services without your own means to be able to assess and to form diagnosis, because we know that families will think the key is in the NDIS, that's where the funding may be, but the barrier to be able to get there is around that diagnosis, key to unlock. They get through the door, and then it's a fight around prioritisation and that strength, as you've talked about trying to advocate and self-advocate for yourself. We also agree that we think early learning centres and early learning environments and play groups and the places where people will come together is a perfect opportunity that already exists in the framework or in the systems that we work alongside. And we see that role of navigation, and we touched upon it earlier today, so important, having people who can walk alongside you, know how the system operates, connect you with the right community centre that has an allied health professional working out of it once a fortnight, for example. You can't necessarily find that on the internet. Having those local people who can take away some of those barriers. Our submission talks around a Links to Early Learning program that we've been working on in southwest Sydney, and not all early learning centres can support people and children with disability or developmental delay. It's a real barrier. We heard that earlier today as well. But working with providers that are delivering those supports to take away some of those other barriers that are not financially motivated to have access for children when we don't actually know what's necessarily going on for them. Connect you with other mums and dads, connect you with the early childhood educators, and know what's happening in the community and bring the community into those centres.
So, and you provide support to those centres in terms of... In
terms of capacity building and understanding what might be happening, and looking at other different funding avenues or other training, other roles that could come in to support that pathway into the early learning setting.
Yeah.
Sorry, if I could just add as well,
Sure.
speaking to our services, they talk about the fact that families have so many conflicting needs. They were talking about a family that was seemed to be homeless, and they have a child with disability and developmental delay, and they said, how can we be seeking diagnosis when our priority is that next week we may not have a home? You know, that diagnosis doesn't exist as their single priority. There's so much else happening in their lives, and additionally, if the financial barrier is there, there's just so many things, and they love their children. These are parents who care so deeply, but they just have so much else happening in their lives.
Yeah. Yeah. Okay. Any questions, Sophie?
I've got a question, and I heard child learning hubs being mentioned. Just in practice, where would they be set up? Out of interest, like where would they be placed, located, found? And I guess it changes for each community.
Yeah, exactly. So child and family hubs, I think the best thing about that model is that they look different.
Yeah.
So we participate in a model in Ashcroft, which is based in a school, and so the services are interconnected with the school, and we're part of a kind of broader partnership that works with that. I'll let Lisa speak to Village Connect, which has a slightly different model, which is online based and not necessarily located as single location. So child and family hubs, they are centred where families and children already go. So they need to be in places where you're reducing that barrier to access, and then they should be bringing together multiple services. So it means that they can go to that single place and they can be connected with what they need. But I'll just let you speak to Village Connect.
Yeah, Village Connect is another early intervention program piloted in southwest Sydney, and it's looking at young mums, pregnant and newborn mums.
I think that's partly my electorate.
Hey, whoa, good on you. Happy for a visit anytime.
Already been there.
Yeah, oh, good. Even better. So, yeah. And so it's a partnership in relation to Karitani, our Navigator service, and Sonda, who provide the actual infrastructure around the technology piece for after hours and mental health support. So it's tapping into local services, professional services, and also the use of technology.
Yes, Ms. Power, you'd like to...
No, she's turning the light on.
Yeah. I was trying to turn the lights.
Oh, sorry. I thought you were signaling that. Sorry.
Provide a response. Thank you. Just following up from what Uniting was mentioning, we have examples in Western Australia where we have the Department of Education-led child and parent centres, which really brings in early childhood services into the school system. And they do so also by bringing in a health nurse into the school and providing parents the ability to really be aware of what to see within for the children, to understand whether the children are having developmental delays. As was previously mentioned, many of the parents don't have the health literacy skills. So some of the school-based and school-supported hubs, which are more integrated between early years and the schools, can really help parents to navigate the system better and have a better awareness of the challenges and the delays that their children are experiencing as well.
Yeah, I mean, we are looking hopefully to try and make sure that people can recognise those issues before school in younger kids, so that early intervention can do what it's meant to do. So we're looking in the early childhood centres as well. But those sort of soft referrals are important, I think, very important.
Community play groups are another.
I think they're fantastic.
Really good opportunity.
Yes.
It's already in place, and
Yep.
so looking at further investment or re-coordination of those resources to make a difference for this particular cohort.
That program we talked about with Karitani, which I have been involved with, is a really terrific one because it starts before birth. It starts with the young mums, during pregnancy.
Yeah, to scale a program like that would absolutely have huge impact.
Yeah. Good. Any questions? Yeah, Annette.
The program at Ashcroft, which is in my electorate, does it do the other suburbs around it, or how are you just working with the children who are going to Ashcroft Public School?
So it's actually coordinated by ANCOS, so we're a partner, but it's not our kind of service to deliver, but we'd be happy to provide more information if that's something that would be useful for you.
Yeah, sure, that'd be great. And I actually sponsor a child through the Smith family, have done for some years, so it's interesting to see that young person through support that you give back to the sponsor about how they change year to year on what their goals are and so forth. It's been really interesting to be part of that. I wondered if you wanted to comment. We have heard time and time again that the system is not working, that nobody's got supports, nobody can navigate the system. We had a very articulate mum just before who has had to battle to get that. But there is lots of funding going into all of these areas that you provide services in, all of you, which is clearly not being utilised as well as it can be. Do you have a suggestion how that could change with the funding envelope you currently have? Because we're funding a lot, but we're not getting anything out of it. So something needs to change. Do you have any suggestions about what we could suggest that change might be?
We can go. So it's a kind of good timing for that question because we've just started our own internal mapping of looking at what are our services, how are they funded, and then thinking about where could we be making similar recommendations. So as a provider, we have such a diverse range of services. We receive so many different funding packets, and so we actually want to know where we could make similar recommendations. So that's at a bit of an early stage still, but as that develops, we'd be more than happy to share. But absolutely agree, we're getting funding into services and why are they not working? And with that, we also see that there are services that are overserviced, where there's duplication, and so you're ending up with parents who are finding it difficult to navigate because there's just so much. And then we have areas which are underserviced and there's just nothing at all. And so the role of government, we think, is to look at where that funding is. How can it be used more flexibly? Can we enable providers to work together across different funding streams? What can we be doing to make sure that we're not just having repeating the same mistakes? So, Lisa, I don't know if you want to say any more.
Yeah, and it goes back to our opening statement in terms of thinking about that universal access at a national level and ensuring that at that local level it looks different in different places depending on what those needs would be. But harnessing where those resources are coming in, even as an organisation, we can see really big pockets, and we talked about regional and remote earlier, where that infrastructure just isn't there, those providers aren't there, the incentives haven't been necessarily mapped out for either in the NDIS space or in earlier intervention. We've seen on the landscape around where the buckets of money are across the jurisdictions, we see it very heavily weighted obviously in the NDIS, and we absolutely understand this is a challenge that government has, and we can see the compelling story here. But down in that early intervention end, it's really light on. Light on. And so we see that's where the opportunity is to either relook at some diversion around investment.
Very good point. Thank you. Ali, do you have any?
We absolutely support the intent of that. Just to add in, I think really needing to think about where the incentives are built into the system, and in the schooling system, diagnosis for a number of children releases a resource to the school, but it means that the way the system is set up at the moment, it requires quite a number of families to go through the assessment system in a way that is, with the right supports in the schooling system already, you might be able to not have families need to do that. And the sort of process of assessment, diagnosis, and then support probably isn't necessarily the best way forward for a number of families who have children who are at the milder or moderate end of the sort of spectrum of disability.
Yeah, no, we understand that. Ali, do you have any questions? No. Good. Well, look, I'm afraid we have run out of time, but thank you very much for attending here today. It's been very valuable to hear your main issues, and your submissions will be certainly part of our final report. Thank you for all the work that you do. We recognise how important it is. If you've been asked to provide any additional information, could you please forward it to the Secretary by the 14th of November 2025. You'll be sent a copy of the transcript of your evidence and will have an opportunity to request corrections to any transcription errors. And once again, thank you for appearing today. I will declare this public hearing closed. I'd like to thank the Secretariat and my fellow members of the committee for all their work, and thanks for coming today. Thank you.
Thank you very much.
Thanks.